Welcome guys. So we will start now. Warm greetings to the respected dignitaries, organizers, delegates, and one and all assembled here for today's session. Heartiest welcome to this preliminary round of Dhanvantari case presentation event under Confluence 2020. I am Arya Desai, third minor MBBS student at SAIT GSMC and KM Hospital. It gives me immense pleasure to host the finalist of the preliminary round as they enthrall us with some of the most intriguing cases which form the richest source of learning in medicine that could ever exist. So without further ado, let's dive into this year's preliminary round of case presentation competition, where no aspect of medicine is left untouched, a tussle that will tickle your brains and quench your curiosity. Starting with the session, honorable judges for the day are Dr. Neena Khanna. She was a former academic dean and head of Department of Dermatology at All India Institutes of Medical Sciences, Delhi. She has around 80 research papers to her name and 170 articles in Index Journal. She has been author and co-author of about 9 books, including The Illustrated Synopsis of Dermatology and Sexually Transmitted Diseases. Welcome, ma'am. We are really glad to have you on board. Then we have with us Dr. Arvind Bagga. He is professor and head of Department Pediatrics at All India Institutes of Medical Sciences, Delhi. He is Secretary General of Asian Pediatric Nephrology Association and editor of Asian Journal of Pediatrics Nephrology. He is renowned co-author of pediatrics book Ghai, Essential of Pediatrics. Welcome, sir. We are really glad to have you on board. Now, let's quickly brush through the rules and judgment criteria for the preliminary round of the competition. So the format of the presentation is, the presentation should be strictly in MS PowerPoint in landscape form. The flow of the slide should be as follows. The first slide containing the title of the case along with the name and affiliation of the authors and co-authors. Then the second slide about the history of the case. Third slide about the clinical examinations done. Fourth about the investigations done. Fifth about the differential diagnosis and final diagnosis made. And sixth about the management and intervention. Keep the presentation short and simple and highlight the important points. The presentation time of maximum 4 minutes will be allotted to the presenter, which will be followed by 2 minutes Q&A round conducted by the judges. In case both the author and co-author are attending the event, only the author is allowed to present the case, and co-author can answer in the Q&A round. So the presenters will be judged on the following points: relevance and originality of the case, proper proposition of the diagnosis and intervention, solid literature search done, quality of the presentation, oration skills, and response to the questions put forward by the jury. Please everyone make note that there shouldn't be any interruptions. Marks will be deducted if the presenter extends beyond the given time limit, and a warning bell will be given at 3 minutes. So now let's have our first case by Aman Goel.
Yes, ma'am. Good evening.
Hello, Aman. So shall we begin?
Yes, ma'am. Sure.
Yeah. So your time starts now.
Ma'am, you have disabled the screen sharing. Ma'am, you have to unmute yourself.
I'll give you the permission. Just a second. Just try now if you can share.
Yes, ma'am.
Yeah. So you can.
Ma'am, can you see the slide?
Yes, it's visible. Go ahead.
Good evening to all the respective judges. I am going to present Dhanvantari case presentation on the topic, the rare case of internal hernia of partial volvulus right colon through foramen of Winslow and its management by laparoscopic approach. The authors and the co-authors are Dr. Bipanpreet Kaur and Dr. Saurabh Nada. The contents of this presentation are case presentation, discussion, conclusion, and references. Case presentation. A referred 46-year-old female patient presented to Adesh Emergency Surgical Department, history of sudden onset abdominal pain, episodes of constipation and loss of appetite. On examining, the abdomen was distended and slightly tended in epigastrium, Foley's urinary catheter, and the Riles tube in situ. Past history of episodic abdominal discomfort for the past 2 years was present, which was relieved by medication prescribed by the local private practitioner. The abdomen and the pelvis region with oral and IV contrast was done in the emergency department. The CECT of the abdomen showed midgut malrotation with reversal of superior mesenteric artery and superior mesenteric vein. Foramen of Winslow hernia containing the grossly distended right side colon in the gastrohepatic recess with volvulus. No evidence of pneumoperitoneum was seen. The patient was admitted for the urgent laparoscopic procedure. For the surgery, two 10 mm ports, suprapubic and supraumbilical, and two 5 mm ports, right and left, mid-clavicular line respectively, was made. On the diagnostic laparoscopic, intraoperative findings were herniating hepatic flexure and ascending colon through the foramen of Winslow. The herniating content was axially rotated with the bowel congestion due to the venous flow obstruction. With the gentle traction of the hernial contents were reduced completely, and the primary closure of the foramen of Winslow was done using the 3O barbed pre-knotted suture. Omentopexy of the hernial orifice was not feasible because there was no significant intraperitoneal free omentum present to do the same. There was no need for the bowel resection since there was an appropriate viability of the colon. Due to the band attached to the appendix, suspected to become the leading cause for the hernia of this colon, the appendix was mobilized and ligated at the base, and the catgut chromic suture was used to cut at the base was ligated and the appendix was cut. And the cecopexy was done with proline 3O transfacial suture in the right life fossa. Intra-abdominal drain was placed, which was removed after 24 hours due to the nil count. The patient was tolerating oral liquids and semi-fluids after 48 hours of the surgery. The patient was discharged on the fifth post-operative day after confirming no complication. Patient is now doing good on follow-up. The foramen of Winslow hernia is also known as epiploic foramen or the omental foramen. Herniation of the bowel through the foramen of Winslow is a rare kind of internal hernia that comprises of only 8% of the all internal hernias and 0.08% of all hernias. Only 150 cases of foramen of Winslow hernia have been described in the literature. Internal hernias are defined as protrusion of the intestine into the large fossa, cystic space, or defect that causes the bowel obstruction, resulting in symptoms like abdominal distension, nausea, and vomiting. Internal hernias are of two types: peritoneal fossa and peritoneal defect. Peritoneal fossa are periduodenal hernia, pericecal hernia, foramen of Winslow. Peritoneal defects are defects in mesentery, omental defects, and uterus band. The foramen of Winslow is defined superiorly by the
Thank you for such a wonderful presentation, Aman. It was really up to the mark. Now we'll begin with the Q&A session by the judges.
Can I stop the screen share?
Yeah.
So Aman, I think well presented case, and I think, so obviously it's a rare entity. So are there any chances of recurrence of this condition again?
Sir, we did the primary closure of the foramen of Winslow with the 3O barbed suture. So, and we also done the cecopexy. And with that, we attached the cecum to the lateral abdominal wall with proline 3O transfacial suture. So there is chances. Until now, we haven't seen the recurrence in this patient.
So any reports of recurrence happening following these internal hernias?
Sir, to my best knowledge, I haven't seen any recurrence in this. But if there are chance of increased abdominal pressure, then there might be a chance that the recurrence can occur.
Okay, thank you.
What complications were you looking for in the post-op period?
Ma'am, the complications we were looking for, ma'am, ma'am, for the abdominal sepsis, ma'am, we could have seen the sepsis in the patient because of the, and we have shoulder pain in the, because of the pneumoperitoneum, but there wasn't any shoulder pain in that patient.
Okay, no, specifically, no, sepsis is any a complication of any surgical procedure, but specifically in this particular patient, was there anything specifically you were looking for?
Ma'am, the mesentery of this patient was very hypermobile. So we were thinking of like if there can be a hernia in between the bowel loops there. So we were looking at that. In Peterson hernia, the bowel loops get attached to bowel loops get behind each other's, and there is a hernia over there, and it gets strangulated. So we were hoping that it wouldn't occur that.
Okay, well done, Aman. Very well done.
Thank you, judges, and thank you, Aman. Now we'll have the next participant, Devanshu. Devanshu, hi Devanshu, are you there?
Hi, hi.
Hi. So can you share the PPT?
Okay.
Judges, is the PPT visible to you?
Yeah, it is.
Okay. So Devanshu, now you can start.
Okay. Good evening, everyone. I'm Dr. Devanshu Kakani from Dr. Vasantara Kaur Medical College, and I'm presenting this very rare case of post-infectious hemophagocytic lymphohistiocytosis presenting as paniculitis. A 40-year-old female was brought by the relative to the casualty with a history of fever, maculopapular rash over abdomen, yellowish discoloration of skin and mucous membrane, breathlessness, and decreased urine outputs in 7 to 8 days. The only significant past history includes nausea, vomiting, and diarrhea 3 weeks back, which was relieved upon taking medications from the local practitioner. She has no significant personal, obstetric, or family history. On general examination, the patient was conscious, well-oriented, and obeying commands with a pulse of 112 beats per minute. BP was 100 by 60 mm of Hg. SpO2 was 99% on 6 liters of oxygen with a respiratory rate of 24 breaths per minute. She was pale, icteric, with bilateral pitting edema and raised AVP. Upon inspection, this is what we saw. As you can see, the rash that she had began to necrose, and the skin and the fat pad began to slough off, and it was entirely covered with a sheath of slough. On palpation, only the spleen was palpable per-abdominally with no other organomegaly felt. On auscultation, bilateral basal grafts were heard. So at this point, we had sepsis, AKI, and fluid overload as differentials. Upon initial investigations, we found the patient was anemic. There was leukocytosis, thrombocytopenia. Ferritin level was normal. D-dimer was raised with deranged PT-INR. Fibrinogen was low. ESR and CRP was raised. LFT showed deranged bilirubin with no evidence of hepatitis. Serum creat was also raised, and on serum electrolyte, serum sodium level was low, which again points towards fluid overload. ABG showed metabolic acidosis. Clinically, the patient looked septic and required oxygen and inotropic support. So she was immediately shifted to the ICU. In ICU, the patient was initially treated as sepsis, AKI, MODS, GIC in view of above investigations. The entire infectious panel was sent to search for the cause of deranged labs. Till then, the patient was started on broad spectrum antibiotics. Central line was inserted. Inotrop was started for the shock. Oxygen support and diuretic infusion was continued. Daily dialysis was done for 3 to 4 days. In ICU, the fat pad began to slough off, as you can see here in this picture. Okay. The entire infectious panel came out to be negative. Even the blood culture and ANA were negative. This is the chest X-ray of the patient taken in supine position in the ICU, which kind of shows cardiomegaly, for which we did 2D echo, but it came out to be normal. CT abdopelvis showed splenomegaly with no other abnormalities. Till this point, we didn't know the focus of sepsis. We were still searching for it, but the hemodynamic status and urine output of the patient started improving, and she was taken off.
1 minute left.
Taken off of inotrops. RFT and LFTs improved, but the persistent issue was anemia and thrombocytopenia, despite multiple blood transfusion and darbepoetin. for which we consulted our senior physician and hematologist who suspected it to be a hemophagocytic syndrome, for which we sent bone marrow biopsy. On bone marrow biopsy, evidence of hemophagocytosis and suppression of erythroid series was seen. So retrospectively looking, this case fulfills 5 out of 8 diagnostic criteria of HLH. So final diagnosis is hemophagocytic lymphohistiocytosis secondary to unknown primary infection, which presented as paniculitis, AKI, and septic shock. Management and intervention: after the AKI resolved, the patient became hemodynamically stable and patient was shifted to the ward. High dose of dexamethasone was given and surgical debridement of ulcer was done twice. And all the slug was debrided. Granulation tissue was healthy. The patient's condition improved and was happily sent. Thank you.
Devanshu, so it was really a great and wonderful presentation. It was a really informative and interesting case. So
Thank
now
you.
we will begin with the Q&A round with the judges, and you can stop screen sharing.
Okay.
Okay, Devanshu, what other ways can you establish a diagnosis of hemophagocytic syndromes?
Ma'am, blood culture. Blood culture might show.
How would blood culture show?
Blood culture would show pancytopenia or bi or tricytopenia. Even the hepatosplenomegaly, there was this diagnostic criteria, ma'am, which had 8 criteria, which includes fever, splenomegaly, evidence of hemophagocytosis in bone and liver, raised ferritin level, decreased fibrinogen or increased triglyceride level, and this soluble IL-2 receptor level is decreased, increased ferritin, and yeah, that's it.
No, any other way? See, what made you think of a hemophagocytic, apart from the fact that a senior consultant helped you? You did a bone marrow, no?
Mm-hmm.
What about doing a skin biopsy in this particular patient? Because you made...
Ma'am, we actually did skin biopsy. We had suspected it to be a vasculitis, but then skin biopsy came out to be normal. And also, ma'am, even the thrombocytopenia and anemia was not resolving even after giving multiple blood transfusions and apopoietic, which means there is something which is kind of eating new cells. So that's why we thought it could be a hemophagocytic syndrome.
Okay, good.
Thank you, Devanshu, for a nice presentation.
Thank you, sir.
So what antibiotics were you using?
So metronidazole, meropenem, and doxycycline were used.
Doxycycline.
Yeah.
Did you cover for staph as well?
Sorry, sir.
Staphylococci.
Ticoplanin was given for that, sir.
Okay, and I was a bit intrigued, that you decided to choose dexamethasone over, say, IVIG. Was IVIG thought of using intravenous immunoglobulin?
Sir, IVIG is given after dexamethasone, sir. After this getting stable, patient becoming stable.
Okay, all right. Thank you, Devanshu. Thank you.
Thank you, sir.
Thank you, Devanshu. So we will now have the third case. So we have with us Harish Shekhar. Hi, Harish.
Hi, am I audible?
Yeah, you are audible. Can you share the PPT?
Yeah, one moment.
Yeah. Judges, can you see the PPT?
Yeah, we can.
Yeah. Okay, so Harish, you can begin.
Okay, good evening. I am Dr. Harish, an intern from Rajashri Medical College, Bangalore. Here is a rare and interesting case of Sturge-Weber syndrome overlapping with Klippel-Trenaunay syndrome. Coming to the case, here is a male patient, 9 years old, named Dhanush, hailing from Talakadu, whose informant is a mother and who is reliable. Came with complaints of 2 episodes of involuntary movements of upper limb and lower limb since one day. A 9-year-old male who is first born to a non-consanguineous married couple, and since birth, the child has reddish pink rash over one half of the body. The child is immunized till date according to National Immunization Schedule with global developmental delay. Here are the pictures of the rashes. The child is a clinically suspected case of Sturge-Weber syndrome with seizure disorder on multiple anti-epileptics and requiring hospital admissions once in 2 to 3 months in view of recurrent seizures, and was brought to our pediatric triage area in the emergency room by the mother. The mother complained of 2 episodes of involuntary movements of both the upper limb and lower limb with uprolling of the eyes lasting for 2 minutes, followed by loss of consciousness lasting for 2 minutes, following which the child has been drowsy. There's also a history of non-compliance with antiepileptics and history of missed antiepileptic dosage. On clinical examination, anthropometry revealed head circumference was lesser, which showed to be microcephaly. Head-to-toe examination is explained using these images. The right half of the face appears hypertrophied, and the head appears small with flat occiput with brachycephalic head in the left image. These are the images of the port wine stains, which are present in the patient, which is specifically present in the left half of the body. And this is extending from the forehead to the toe. And it crosses the midline in some areas of the body. Here is an image of a blue sclera, and here is an image of a hypertrophy of the mid-thigh and calf. On CNS examination, higher mental function was, the child was drowsy. On motor system examination showed hypertonia on the left upper limb and lower limb, and superficial reflexes were normal, deep tendon reflexes were brisk. Here is a video of a reflex showing exaggerated knee jerk. CNS examination was normal, and other systemic examinations were normal. Laboratory findings, fundoscopy revealed glaucomatous changes with cup to disc ratio of 0.8 to 0.9. So based on the clinical history and examination, I come to these differentials of Sturge-Weber syndrome, Klippel-Trenaunay syndrome, and Park-Weber syndrome. For further investigations, NCCT of the brain was done, which showed tram-track calcifications in bilateral brain parenchyma, and bilateral choroid plexus enlargement was also seen. MRI of the brain
Harish,
showed
1 minute
atrophy.
left.
MRI of the brain showed atrophy of the brain, and MR venogram of the brain was normal, which was done to rule out Park-Weber syndrome. Genetic analysis was also sent, and the reports was awaited. For management, clinical management, aggressive management of seizures with multiple anti-epileptics, that is carbamazepine and levetiracetam was given. Surgically, some studies have shown that 80% of the patients were seizure-free post-hemispherectomy. Long-term prophylaxis with low-dose aspirin is also considered. Cosmetically, pulse dye laser therapy is considered for port wine stain. The discussion of Sturge-Weber syndrome and Klippel-Trenaunay syndrome are 2 different entities within the spectrum of vascular malformations, predominantly caused by gene and somatic mutations. Clinically, the patient presented with recurrent seizures, intellectual disability, port wine stain from forehead to sole,
Time up,
tram-track
Harish.
calcification. Okay.
So all the facts and information was put forward really well. It did a great presentation. So we will now move with the Q&A round.
What genetic changes were you looking at? You said you sent it for genetic analysis. What genetic changes would you expect in such a patient?
Harish, are you there?
Hello, am I audible?
Yeah, you're audible.
Yeah, sorry, there is an internet issue.
Ma'am, could you just repeat the question?
You said you sent tissue for genetic analysis, no?
Yes, ma'am.
So what are you expecting? What genetic changes are you expecting in such a patient?
Ma'am, Sturge-Weber syndrome is seen to have somatic gene mutations in GNAC genes, and Klippel-Trenaunay syndrome has PIK3CA gene mutations. So we're looking for positive findings in those aspects.
And what tissue have you sent?
Ma'am, the affected tissues, ma'am, like the affected side of the body was the punch biopsy was taken and sent, ma'am.
Okay, thank you. Well done.
Thank you, ma'am.
Harish, well done. I think well presented. If I were to think of two different conditions, in the same child, especially if it's a somatic gene mutation, why not only one condition, maybe just a variant of Sturge-Weber? Because the way you presented it looked more and more like Sturge-Weber per se, all the features. Yes. So why do you think there's overlap?
Sir, in view of Klippel-Trenaunay syndrome, there is extensive port vein staining involving the trunk and extremities, which is crossing the midline. And in Sturge-Weber syndrome, it specifically affects the trigeminal area. So, and also in Klippel-Trenaunay syndrome, there's hypertrophy of the face and the lower limbs, which are seen, which is also consistent with this case. So, in view of that, we thought of an overlap between Sturge-Weber and Klippel-Trenaunay.
Are there any previous reports saying that these two conditions, these two different neurocutaneous syndromes could coexist?
Yes, there are 2 to 3 reported cases in worldwide that have been reported that there is an overlap with Sturge-Weber and Klippel-Trenaunay syndrome.
Okay, thank you. Thank you, Harish.
Thank you, sir. Thank you.
Thanks.
Thank you, ma'am.
Thank you, Harish. Now we'll move with the fourth presentation. So we have with us Hemlata.
Hello, ma'am.
Hello, Hemlata. Could you switch on your video? Like you're not switching on your video, kya? It's not visible because. Yeah, it's visible. Hi, Hemlata. Just unmute yourself. Can you share the PPT? Yeah. Judges, is the screen visible?
No.
Yeah, just her screen.
The screen is hard.
The
presentation is not visible.
Yeah.
Okay, Hemlata, please start with your presentation.
Is visible, ma'am?
No, not yet.
No, it's not visible. Just try, Hemlata, if you could start with the presentation. Otherwise, just, yeah, it's visible.
No?
Yes.
Get it on full screen.
Yeah, it's in full screen, ma'am.
No, I mean, start with the presentation in the view.
Slideshow.
The slideshow.
It's already in slideshow.
Just to go on the slideshow and click pay there. Actually, it's in the home. Go on the slide. Yeah, now
Yeah,
it's
there
visible.
it is. Yeah, it's now it's good.
Okay, Hemlata, now you can start.
Good evening, judges. Myself, Hemlata, 4th semester, second year MBBS student at Jipmer. I'll be presenting a case of a transient low.
Hemlata, we couldn't hear you. Are you there?
I think she has some network issue.
Yeah, ma'am. I'll just try to connect with her, ma'am. If she had some issues, we can move with the next participant. I'll just let you know in a minute. Ma'am, we will not wait. We'll ask her to present later.
Yeah, we can ask her to the next one.
We'll have the next participant. Just a second. So we have with us Harris Richard. Hi, Harris.
Hi, can you hear me?
Yeah, I can hear you. Can you share your PPT, Harris?
Yeah, just a moment.
Yeah.
Is my screen visible?
Yes, judges, is the screen visible to you?
Yeah, but he should get on to slideshow. Yeah.
Yeah, just have this.
Yeah. May I begin?
Yeah, start Harris.
Good evening, everybody. I'm Harris Richard, an intern from Coimbatore Medical College. And today I will be presenting a case of metastatic penile cancer with scrotal infiltration. So before we go into the case proper, I'd like to give a brief introduction about the topic. So penile cancer is a relatively rare cancer of the male genital urinary system with an incidence of less than 1 per 100,000 males. So this incidence varies according to several factors such as circumcision practice, phimosis, hygiene, HPV infection, and other factors. And it commonly presents between the ages of 50 and 70 years, and the most common type that presents is squamous cell carcinoma. So with this in mind, let's take a look at the case. So the case is of a 55-year-old uncircumcised man who was known smoker and alcoholic who presented with a growth on the penis for the past 5 months. The growth is progressive with sloughing out of the penile skin, associated with pseudopurulent to pseudohemorrhagic discharge. There is history of difficulty in micturition present. History of scrotal swelling is present for the past 10 days. On examination, on inspecting the lesion, we find an ultraproliferative growth of size 8 cross 6 cross 3 centimeters, noted at the tip of the penis, involving the shaft up to the distal 2/3 of the penis, with destruction of the prepuce. The growth surface and margins were irregular, purulent discharge was present, bilateral scrotal swelling was present, scrotal skin rugosity was intact, and there was no visible redness. On palpation, inspectory findings were confirmed. The growth is hard, it bleeds on touch. Induration is noted at the proximal end of the shaft, with the urethral remiatus still visible, and there were no palpable strictures. The scrotal skin was thick, tender, and hard. Testes were not palpable. Bilateral multiple inguinal lymph nodes were palpable, which were the horizontal group. They were hard, fixed, and non-tender. On palpating the abdomen, it was soft with no organomegaly. On investigating this patient, we performed a contrast-enhanced CT. We found heterogeneously echoing ultraproliferative lesion on the penis with the scrotal wall thickening. Bilateral testes were normal with moderate peritesticular collection. Prominent vascular channels were noted in the left peritesticular region. Heterogeneously echoing masses were noted in the bilateral inguinal regions, the largest of size 3.5 cross 5.2 centimeters on the right side, 3.2 cross 2.5 centimeters on the left side. Bilateral external and internal iliac lymph nodes were noted. Para-aortic nodes were also noted. On performing a CT chest, there were no lung metastases. Histopathology of the lesion revealed a moderately differentiated squamous cell carcinoma with an Fnsc of the nodes revealing features suggestive of carcinomatous deposits. So with this history and examination findings and the investigations performed, we arrive at a diagnosis of penile carcinoma of stage T4 due to scrotal infiltration, N3 due to the involvement of the iliac node, and N1, which makes it a metastatic disease due to the presence of the para-aortic nodes. So the patient, because of the advanced stage of the disease, the patient was started on palliative chemotherapy. We wait for the assessment of response to chemotherapy is to be done. If regression of the retroperitoneal nodes is noted, we plan for a total penectomy with ilioinguinal block dissection, bilateral, with perineal urethrostomy. So distant metastasis in cases of penile carcinoma is relatively uncommon, and when it does occur, it carries a very poor prognosis. Pelvic node metastasis is a very grim finding with a mean 5-year survival of 5 to 10%, with most people not surviving beyond 2 years. Hence, clinical examination of the inguinal lymph nodes is vital, as nodal involvement is obviously a very poor prognostic factor. Moreover, penile cancer is capable of early detection. It is not missed easily because of the superficiality of the lesion. However, many patients they present at very advanced stages. Okay. Many patients present at very advanced stages, and this is obvious due to psychosocial inhibition. And as with any disease, early detection and management is vital in providing a better prognosis and a better outcome in terms of morbidity and mortality. These are my references. Thank you.
So thank you, Alice, for a nice presentation. So what forms of therapy are effective and they do help in better 5-year survival in these patients? You said chemotherapy. So which forms of therapy are effective in treating these patients apart from surgery?
So we can also advise radiotherapy and chemotherapy. So
which drugs are commonly used for chemotherapy?
In terms of chemotherapy, we have a VBM regimen, which is vincristine, bleomycin, and methotrexate. For palliative chemotherapy, we also use cisplatin and paclitaxel. Yes.
What are the key side effects of, say, bleomycin or vincristine? Okay, it doesn't matter. And what about radiotherapy? How much radiotherapy would you normally give? That would depend on the stage, I agree, but what any gross idea as to the...
So we normally advise a radiation of 60 grays, sir, for a radiotherapy. And as a prophylactic measure, we also advise 40 to 45 grays in terms of radiotherapy.
Okay, thank you, Harris. Thank you.
Thank you.
How old was your patient?
My patient was 55 years of age, ma'am.
Did you get his sexual history? And is it important?
Yes, ma'am. It is important in this case. He does not claim to have any multiple sexual partners or any sexual relations outside of his marriage. He has 2 children. This is important because of HPV infection. It is one of the risk factors for the development of penile carcinoma.
And which type of HPV is oncogenic?
HPV 16 is oncogenic, ma'am.
That is one.
HPV 30, 33, and 39 are also oncogenic.
More frequently? Is there any way you can prevent penile malignancies or cervical cancer due to HPV?
Yes, ma'am. Vaccination is done, ma'am. Vaccination, ma'am.
Which vaccine?
HPV, human papillomavirus vaccine.
How many types of HPV vaccines are there? Doesn't matter. Okay, well done. You presented very well. Thank you.
Thank you.
Thank you, Harris. It was really informative and interesting case. So now we can have the next participant. Actually, Hemlata is back. So we'll have Hemlata.
I'm sorry.
Yeah, it's okay. I guess your internet is not that strong. Just you could switch off your video and then also you present, it will be great. Then your voice will be properly audible.
Switch off?
Just share. Yeah, switch off your video.
Okay, fine.
And just go ahead with the presentation. Can you share the PPT?
I'm scared.
Yeah. Judges, is the PPT visible to you now?
Yeah, it is.
Yeah. So Hemlata, you can start with your presentation now. You can start your video in the Q&A session.
Okay, ma'am. Good evening, judges. Myself, Hemlata, second year MBBS student at Jupmer. I'll be presenting a case on transient low tide of time. The history of the case is that the chief complaint, the patient presented with 3 months of amenorrhea, bilateral pedal edema for 1.5 months, which has progressed to facial puffiness and abdominal distension in the past 2 weeks. She had breathlessness for the past 2 weeks. History of presenting illness, a 22-year-old unmarried woman hailing from Tamil Nadu. She reported amenorrhea for 3 months with a previously normal menstrual cycle with no significant previous history. We also elicited fever that she had since 3 months, which was low-grade intermittent fever of 7 to 8 episodes per month with evening rise in temperature, which was not associated with chills and rigor. Swelling of the body, she also reported painless swelling of both upper limb, lower limbs for 1.5 months, which gradually progressed involving abdomen and facial puffiness for past 2 weeks. She had history of breathlessness on exertion since 1.5 months, which has gradually worsened over 2 weeks. Coming to the examination, the general examination was significant for the severe pallor and the anasarca she had. Her pulse rate were high, BP, SpO2 temperature were normal, respiratory rate was high. On systemic examination, her respiratory system, she had absent breath sounds on the left side with dullness to percussion. All other system examinations were unremarkable. Coming to the investigations, her hemoglobin value was low, 4.2. We found that she was anemia. We admitted her as a case of anemia and failure. Total leukocyte count was low, platelet count was on the lower limit, serum albumin was also low. But the urine routine microscopy were normal, LFT coagulation profile were normal, ECG echo were normal, chest X-ray showed as suspected left-sided pleural effusion. At this point, the cause of low albumin was unknown. As a part of hypoalbuminemia workup, the urine routine was normal, LFT was normal. In the absence of any GI complaints, protein-losing enteropathy was least likely. Since the total protein was normal with low albumin and high globulin, the reduced albumin was attributed to the negative albumin being the negative acute phase reactant showing ongoing inflammation. Since the patient had anemia and failure, we transfused one packed RBC and followed by which therapeutic thoracentesis was done. But what happened was that after the transfusion, she developed progressive shortness of breath with hiking fever and tachycardia with no skin and renal problems. The next day, she worsened, requiring oxygen supplementation. On the course, we suspected that maybe the pleural effusion might causing all these. We done therapeutic thoracentesis, but after that, she even more worsened. Her effusion.
Hemlata, 1 minute left.
Yes, ma'am.
1 minute left, Hemlata.
Yeah, okay. Her effusion was transitive and TB tests were showed negative. HRCT revealed heterogeneous consolidation of the left lower lobe with minimal consolidation of the right lower lobe. As you can see, after transfusion, her fever spikes were heightened up. Owing to the ongoing fever spike, diagnosis of TRALI or re-expansion pulmonary edema was made. She was started on antibiotics. After which she was shifted to ICU, from where she had spontaneous improvement in the general condition as well as in all the three cell lines. Meanwhile, the procalcitonin was low, blood cultures were sterile, brucella serology was negative. She showed a spontaneous improvement in all three cell lines. As you can see, the hemoglobin was developing without any intervention. Total leukocyte count was also improving after admission. Platelet count was also improving with reactive thrombocytosis, which is the post-infectious phase. Since there is spontaneous improvement in all three cell lines without any intervention, a transient aplastic crisis was made with a suspicion of parvovirus. Out of interest, we sent the titers which showed positive for IgM and IgG parvovirus glycoprotein. The message is that keeping high suspicion for such.
That time is up.
Yeah, okay, ma'am. I've just completed.
Yeah, okay.
Thank you, ma'am.
So, in a good, interesting case. Yeah. So you think this is parvovirus disease?
Yes, sir.
And how do you explain the edema and everything that she began with? That's all due to anemia.
That is most probably due to the anemia she had, which was in failure, and which was all.
What about the consolidation in the lung?
Sir?
What about the lung findings, the lung consolidation?
It might be because of the transfusion associated consolidation. She only had pleural effusion at the presentation, which is probably due to the anemia and failure and the hypoalbuminemia she had.
Okay, how do you?
Sorry to interrupt. Hemlata, could you just stop your screen sharing?
And Hemlata, how do you treat parvovirus? Suppose you do have parvovirus disease. What's the therapy for parvovirus? How do you treat parvovirus infection, say in an immunocompromised host? Can't hear you well. Any specific therapy?
I don't know, sir.
It's okay. Thank you. Well presented.
Thank you, sir.
Well presented. Tell me just one, can you explain all the findings on a parvovirus infection?
Will have, if it was on hemolysis or hemoglobin, the patient will have transient aplastic crisis. It can also develop to chronic anemia. Some patients may develop into a phase called polyarthralgia, that's why the diagnosis was needed. That's all I know.
Can you get asymptomatic infection?
Yeah, we can get asymptomatic infection in normal individuals with few spikes of fevers, which resolves on its own.
So could this just be that and
the presentation was due to since presentation was anemia and failure because of parvovirus, but
too acute an onset. Yeah, that I think that is what the answer I was looking for. Yeah. Okay, well done.
Thank you, Hemlata. It was really a great presentation. All the facts were really up to mark. So now we'll have the next case. We have with us Lekha. Hi, Lekha.
Hi. Yeah.
Hello. So can you share the PPT, Lekha?
Yeah, sure.
Yeah. Judges, is the PPT visible?
It is, yeah.
Yeah. So you can start now, Lekha.
Good evening, judges. I am Lekha Bengeri, third year MBBS from SDM College of Medical Sciences, Dharwad. My co-author is Sahana and our professor guide is Dr. Kiran Naital, who is the HOD of General Medicine in our college. So today my case is about a case of paradoxical tuberculoma in an 18-year-old girl with tubercular meningitis. So this patient presented to the casualty with chief complaints of fever and headache since 15 days and altered sensorium since 1 day. She had no significant past history, family history, or menstrual history. So in the casualty, we examined her and her vitals were seen to be normal, but she had impaired higher mental functions. She was drowsy and she was in a confused state. There was also neck rigidity present as Brudzinski and Koenig sign were positive, but she had no focal neurological deficits. On fundoscopic examination, she had papilledema grade 2, which is basically a fully developed papilledema where there's optic disc edema and the physiological cupping of the optic disc was absent. The other system examinations were normal. Laboratory investigations which were done on the first admission were lumbar puncture CSF analysis, which showed that the protein levels were highly increased and sugar levels were reduced. The nucleated cell levels were also more, and it was lymphocytic predominant. CB-NAT of the CSF sample was negative, and the MRI brain was also seen to be normal. Electrolytes were normal and serology was negative. So the MRI brain, which was done in the first admission, had normal findings. Now, this patient came back after 30 days of the first admission. At this point of time, patient was prescribed anti-tubercular therapy and she was on steroids. When she was readmitted, she had complaints of headache and this time severe projectile vomiting, which is not present in the first admission. Clinical examination was normal, fundoscopy was normal. Here, when the MRI brain was done, there were multiple ring-enhancing lesions, which were suggestive of tuberculoma, since we had diagnosed her with tubercular meningitis. So this is the MRI brain in second admission, which showed the ring-enhancing lesions. There are 2. Okay. After the second admission, 14 days later, she again came back, and at this time she was on ATT steroids as well. She had repeat complaints of headache and vomiting. Clinical examination findings were normal, and the CT brain revealed mildly dilated ventricles suggestive of hydrocephalus of obstructive type. The repeat CT brain after 1 week showed no deterioration of hydrocephalus. So the clinical and CSF picture initially was highly suggestive of tubercular meningitis. Along with this, tubercular meningitis is the most common form of meningitis seen in India. So intensive phase of ATT was started. Post ATT treatment of 1 month, there were new MRI brain findings of ring-enhancing lesions, which were highly suggestive of tuberculomas, and there was also development of hydrocephalus of the obstructive type. So for management, like I said, initially first-line ATT was started. Once the neuroimaging confirmed tuberculoma after 30 days of starting ATT, the intensive phase of ATT was continued for 1 more month with dexamethasone, and albendazole was also given for 14 days. For the hydrocephalus, IV mannitol was given to reduce the intracranial tension. Steroid was continued for 2 more weeks for a total period of 6 weeks.
Lekha, 1 minute left.
A repeat MRI after a week was normal and showed no deterioration of the hydrocephalus. So to conclude this case, tubercular meningitis is a form of meningitis which is very common in India, and it is not a very unique phenomenon. But here in this case, after 30 days of starting intensive phase of ATT, patient developed tuberculoma. And there was worsening of her symptoms. And this is been attributed because of an excessive inflammatory response which develops to the ATT because of immune reconstitution and excess antigen exposure after administration of ATT, following which the tuberculoma develops. So the main importance of this case is to stress on the fact that upon starting of ATT, it is important to monitor the patients for their symptoms, because some patients can have worsening of symptoms. And usually these tuberculomas develop within a span of 3 months to 12 months, but here it developed in a span of 30 days. Thank you.
Lekha, very good, very clear presentation. Thank you. Lekha, I think iris is kind of recognized more and more often now. So what's the overall prevalence of the immune reconstitution syndrome in patients who are treated for tuberculosis?
Any
idea about the numbers?
I'm not very aware of the numbers.
Would there be some patients who are at high risk for the immune reconstitution, or it doesn't matter, it's just a matter of chance?
Actually, tuberculomas have been seen to occur more commonly in the younger age group.
But the reconstitution thing is also more popular in the younger age group.
That I'm not aware of, sir.
And why did you why did you use albendazole when your diagnosis was iris?
This was as a measure to ensure that these ring-enhancing lesions are not due to any helminthic infections.
Or see, that would be an odd thing, because then you probably have two conditions happening simultaneously. So you have tuberculoma with cysticercosis.
Yes, sir.
So that was thought of as well. Okay.
Yes, sir.
Thank you. Thanks.
Thank you, sir.
Well done. Taking off from where Dr. Arvind's question is there any way you can prevent such a reaction from developing?
There's actually no predictable factor for this reaction to be prevented as such, but one thing that can be done is when ATT is started, patient can be very closely monitored, and as soon as there is a worsening of symptoms, they have to be treated as soon as possible.
And aggressively.
So actually this patient, initially in the first month, she had worsening of symptoms, but after she was brought in, admitted, and there was aggressive therapy done, she was much better. But the initial 1 month of treatment, there was worsening of symptoms.
So what you need to do is to counsel the patient and handhold the patient and tell them that they should immediately report in case there is a aggravation.
Because most patients upon starting of ATT, they assume that, okay, they will become all right. But here, in some cases, there is worsening of symptoms.
So Lekha, thank you for such a great presentation. All the facts were really put forward well. So now we'll have with us Netra. Hi, Netra.
Hi, am I audible?
Yeah, you're audible. Yeah, you are visible also. Can you share the PPT, Netra?
Sure.
Yeah.
Just a minute.
Yeah.
Is it visible?
Yes, it's visible. Judges, can you see the PPT? Judges, is the PPT is visible, right? Yeah. So Netra, you can begin with your presentation.
All right. A very good evening to everybody. I am Netra Jain, and I'll be presenting a case on isolated gastroduodenal tuberculosis with gastric outlet obstruction, a diagnostic dilemma. As we all know, TB is very prevalent in the world, of which India has the largest burden, and it can affect any part of the body. However, abdominal TB is particularly difficult to diagnose, and it requires a high degree of clinical suspicion to diagnose it. A 43-year-old male patient presented with chief complaints of pain in abdomen since 4 months and vomiting since 2 months. The pain was insidious in onset, gradually progressive, intermittent, associated with abdominal distension, dyspepsia, weight loss, and nausea. He also had vomiting and loss of appetite. There was no history of any other significant comorbidities. On clinical examination, general and systemic examinations were normal, except a succussion splash was heard on auscultation. On routine investigations, an elevated ESR was noted. ECG, chest X-ray, and erect abdominal X-ray were normal. As for specific investigations, first USG abdomen was done, which showed prominent common bile duct with multiple air foci and an overdistended stomach. So next, an upper GI endoscopy was done, which showed pangastritis, as seen as this red mucosa over here, duodenitis, concentric wall thickening of D1 and D2 segments of the duodenum, and a choledochoduodenal fistula from D1. Biopsies were taken of the mucosa, and they were subjected to smear culture and gene export, which were negative for Mycobacterium tuberculosis. Histopath also showed no evidence of granulomas and malignancy. Sputum gene export was also negative for MTB. So in order to get a more definitive diagnosis, CACT of the abdomen and pelvis was done, which showed pneumobilia seen as these black bubbles in the biliary tree. It also showed mesenteric lymphadenopathy with necrosis seen as this enlarged lymph node with blackness inside, and concentric thickening of D1 and D2 segments and gastric distension. Done to again showed same findings like pneumobilia, concentric thickening of D1 and D2, gastric distension with air fluid level, and mesenteric and retroperitoneal lymphadenopathy. So at this stage, our DDs were GERD leading to gastritis, peptic ulcer disease, malignancy, GDTB, and Crohn's disease. Because a fistula was present, we decided to proceed with Roux-en-Y gastrojejunostomy. Multiple bowel adhesions and caseating mesenteric lymph nodes were noted intraoperatively. The lymph node biopsies were finally positive for MTB on smear culture and gene export, and histopath showed granulomas and caseating necrosis like this. So the patient was started on anti-TB drugs post-operatively. The types of abdominal TB are TB lymphadenopathy, which is the most common, peritoneal TB, GI TB, and visceral TB. GI TB most commonly involves the ileocecal region, and the involvement of upper GI tract is very rare, and two or more forms can coexist as seen in our patient. The sources of infection are hematogenous, which is the most common, lymphatic, contiguous, and ingestion, which is the least common. And primary involvement of stomach is even rarer because of these following reasons. So you can see how rare this case of isolated primary gastroduodenal tuberculosis was. The common complications are obstruction, abscess, perforation, and fistula. Again, fistula is a very rare complication. The treatment usually given is anti-TB drugs with pyridoxine for a year and surgery for complications, usually not required if diagnosed early. I would like to conclude by saying that TB can involve virtually any part of the GI tract, and it can mimic many other GI pathologies. It is difficult to diagnose preoperatively, and therefore you need to maintain a very high degree of clinical suspicion in areas endemic for TB. Often pre-op diagnosis, CACT scans and MRCP are the only clues revealing necrotic abdominal lymph nodes. Often,
Netra, time is up.
Okay. Okay. These are my references. Thank you.
Netra, thank you for an excellent presentation. Can you just tell me what are the current guidelines for treating tuberculosis? Which drugs, how long? And these have been recently revised.
Thank you for your question, sir. Right now, the current guidelines, you're asking for abdominal TB specifically, right?
Yeah, for tuberculosis as such, whether it's, and it's, I don't think it's very much different in abdominal versus pulmonary. Yeah.
So the current guidelines are giving a fixed drug combination, an FDC tablet, which is given daily, and that FDC tablet has combinations of like isoniazid, rifampicin, ethambutol, and pyrazinamide for the first 2 months, which is the initiation phase. And then in the continuous phase, we give isoniazid, rifampicin. This is again given daily. This remains the same for abdominal tuberculosis. I mean, studies recommend this. However, most clinicians, they prefer to give it for a year because of very low quality evidence on the 6-month AKT. So even in our case, we do plan on giving this patient a 1 year of AKT treatment.
Okay, thank you. Thanks.
Thank you.
Well done, Netra. Tell me, you said intraoperatively you saw caseating lymph nodes.
Yes, ma'am.
How did you make out that they were caseating lymph nodes?
On the lymph nodes, they were enlarged, and we had an idea of which lymph nodes were enlarged and necrotic based on the CACT findings, like specifically the mesenteric and the the retroperitoneal lymph nodes. So on they were enlarged, and plus after you dissect them, there was whitish material coming out of the lymph nodes. So that is how I could not unfortunately get a picture of that. But that is how it was seen as caseating. And then, biopsies were taken as well.
Okay, wonderful. Thank you.
Thank you, ma'am.
Thank you, Netra. It was really a wonderful presentation. All the facts were really up to mark. So thank you. Now we have with us Niharika.
Thank
Next
you.
presentation. Hi, Niharika.
Hi, can you hear me and see me?
Yeah. Can you share the PPT?
Yes, I'm
Yes.
doing that right now.
Niharika, is there any issue?
1 second, I'm just trying to upload it. Just give me 1 minute.
Yes.
Um,
Bhagat sir and Neena ma'am, I hope you are enjoying the event.
Yes, and learning a lot.
Yeah, there are really interesting cases now.
Yeah, absolutely. They're well worked up.
Yeah. So Niharika is back.
yeah,
Niharika, can you share the PPT now?
yeah, I'm sharing my screen right now.
Yeah.
Can you see my screen?
No.
Right now, it says sharing.
Are you trying to share through your phone or what?
I'm trying to share through a tab.
Okay.
Can you see my screen now?
It's not visible, Niharika.
Okay, let me 1 second.
Niharika, maybe you should log out and log in again. Meanwhile, we can do the next presentation. You just log
Yes,
out
ma'am.
and log. Sometimes it's that issue, this just doing this resolves the issue.
Yes, ma'am.
Or otherwise, Niharika, you could just send the PPT on the WhatsApp group. We will share it from our side.
Okay, that sounds good. I will send it to you right now.
Yeah, send on the group itself.
Yeah.
Conference Tech team will share it.
Okay.
Yeah. Sorry for the technical issues, ma'am and sir.
One second. I'm just opening it. I will send it now.
Have you sent it on WhatsApp, Niharika?
Yes, it's loading right now. You should be getting it anytime now.
Okay. From which college you are, Niharika?
I'm from KMC Manipal.
Okay.
Yeah. I've sent it on the group.
Yeah, we got the PPT. We will screen share it within a minute. Yeah.
Okay.
Niharika, every time you want to change the slide, just let us know. Key next slide. Okay.
Yeah. Perfect.
Okay.
Okay,
so is it visible?
Yes.
Is the screen visible to you, the PPT?
Yes, it is visible to me.
To the judges, I mean.
Okay.
Yes, we can see it.
Yeah, okay. So we'll start with the presentation.
Yeah. Good evening, everyone. This is my presentation. It's basically aneurysmal bone cyst of clivus, which was misdiagnosed as chordoma. My name is Niharika Reddy, and I'm an intern in KMC Manipal. Can you please change the slide? Yeah, so the patient history is basically a 22-year-old woman who arrived at the general medicine outpatient clinic complaining of early morning headache, nausea, vomiting, blurring of vision, and diplopia in the left eye, which was predominantly on looking towards the left, and it increased with far-off objects. And all these symptoms were progressively worsened over the past 2 months. There was no history of any recent trauma, but there was trauma to the face 5 years ago, causing partially broken left incisor tooth, which was removed 2 months ago. There was no history of menstrual irregularities. Can you change the slide? So clinical examination, on general examination, the vitals were stable. The nervous system showed left side relative afferent pupillary defect, and left lateral rectus palsy was present. The rest of the nervous system examination was unremarkable. Ophthalmological examination showed decreased visual acuity and constriction of the visual fields. So we conducted investigations, and MRI brain was chosen because an MRI gives us a detailed view. And what it showed was a well-defined expansile lobulated heterogeneous soft tissue intensity lesion showing fluid levels and heterogeneous post-contrast enhancement involving the clivus, sphenoid, posterior ethmoidal sinus, and superior turbinate. And this represented a clival chordoma, and that was the radiologist's diagnosis. So for differential diagnosis, since the symptoms involved raised intracranial pressure related symptoms like headache, nausea, vomiting, blurring of vision, that's where the diagnosis kind of led us to. And we thought of mass lesions like localized lesions, brain tumors, hydrocephalus, which is basically disturbances in the CSF, and cerebral venous thrombosis, which is obstruction to major sinuses. So final diagnosis, since clinically we thought raised intracranial pressure and the radiologist said clival chordoma, it was considered as a diagnosis, and that was made to be the diagnosis. And the patient was then planned for neurosurgery and followed by histopathological examination for confirmation. So for the management, the patient underwent a transnasal, transsphenoidal, and subtotal excision of the tumor under the Department of Neurosurgery. And as the tumor was extensive involving the clivus, complete excision was not possible. So intraoperative, the frozen section showed presence of large cells, and samples were sent for histopathological examination. And that examination showed multiloculated cystic spaces separated by fibrocollagenous septae, showing reactive fibroblasts with osteoclasts like giant cells, with areas of hemorrhage and hemosiderin-laden macrophages. So all of this kind of pointed towards aneurysmal bone cyst. And the radiology, the radiology department initially said clival chordoma, but because there was a pathological discrepancy, the preoperative cranial MR imaging was reconsidered again. And then the radiology department said aneurysmal bone cyst diagnosis is probably more likely in this situation. Next slide. So a little bit of background regarding both of these tumors. So aneurysmal bone cyst is basically what the final diagnosis became. This is a benign, rapidly destructive bone tumor that most often affects people under the age of 30. And the usual regions involved are the spine and long bones. Lichtenstein and Jaffe originally classified this in 1942, and the incidence is extremely rare.
Niharika, time up.
Okay.
Time up. Yeah.
So Niharika, thank you for a very clear presentation. Can you tell me of some, here I know there was a history of trauma on that side of the face, but can you tell me some genetic disorders that may cause bone cysts? Some genetic disorders that may cause bone cysts.
Genetic disorders that can cause bone cysts. I'm not sure, sir. I mean, Gardner syndrome causes osteomas, but bone cysts, I'm not exactly sure.
Okay,
So.
don't worry. So how was this patient finally managed?
So at the end, after the tumor was excised, repeated CT and MRI scans were done, and the patient's actually doing well now. So at the end, we found out it was aneurysmal bone cyst only after the histopathological examination. So since the neurosurgery excision was done, the CTs were repeated, and the patient's doing fine now. So
okay, thank you. Thanks.
Thank you, sir.
Yeah, you said the patient didn't have any menstrual irregularities. Why did you ask that question?
Ma'am, actually, according to literature review, there was some conditions where, like the trauma and the menstrual irregularities, we have not found out the reason why, but when I went through a few articles, they said a lot of patients had past history of trauma to the face and menstrual irregularities. So there is no, as of now, there's no exact reason why there is a correlation. We don't even know if it's a correlation or just a coincidence, but that's what was found. Like, that's what I read about online.
Okay, thank you.
Thank you, Niharika. It was really a wonderful presentation. It was indeed an interesting and informative case. Thank you. So we now have with us Pranjal. Hi, Pranjal. You are. Could you just unmute yourself?
Hi.
Hi, Pranjal. Can you share the screen?
Yes.
Ma'am and sir, the event is conducted by said GSMC and KM Hospital, but the cases are from all over the India. The students have participated from all over the India.
Yeah, I saw that. Yeah, that's very good.
Yeah, we have, I guess, 1 or 2 entries itself only from KM. The rest all are from outside the college. Many of them are even outside the Maharashtra. So that is really interesting. It gives us a wide range of cases and variety and adds to our knowledge. And I hope it's interesting even for both of you.
Yeah, it is, Arvind, you recall we recently had Insight where I think both of us were judges also, I think.
Yeah, just recently.
And that was such a, it was such a experience, seeing the youngsters do so well.
Ma'am, there were total 60 entries, out of which we have screened and taken this 20 for the preliminary round. So it was
very
even
good.
difficult.
No, it's very, I think it's very, very good, this spirit of
the response was really overwhelming, ma'am.
Absolutely.
Yeah, ma'am.
And
so I guess, ma'am, Pranjal,
yeah,
ma'am. I guess Pranjal is now ready. Yeah, ma'am, can you see the screen, ma'am?
Yeah, we can see the screen. Yeah.
Okay, ma'am. So now, Pranjal, you can start.
Yes. Good evening to all the dignitaries on board. I'm Pranjal Khirikar. So I'll be presenting FNAC thyroid blood aspirate, a mystery. I'm a second-year MBBS student. So beginning with the history, a 46-year-old female presented with thyroid swelling in front of neck since 2 years. There was occasional pain over the swelling. Swelling kept on increasing to present dimensions of 5.3 into 6 into 4.2 centimeters. There was no past history of trauma, surgery, or any previous FNAC. Also, there was no dyspnea or change in voice. Coming to clinical examination, the swelling was mobile, diffuse, and firm to hard in consistency. Patient was euthyroid, and the TFT was within normal range. Investigations, which included biochemical and hematological, were within limits. Coming to investigations, first we conducted an FNSC. Both FNSCs were conducted, a normal FNSC as well as a USG-guided FNSC. So the USG-guided FNSC showed an enlarged left lobe of thyroid, and it also showed isoechoic nodule with foci of coarse calcification. Now the FNSC had only smear. FNSC smear had only blood without any cells, which made the FNSC inconclusive. Then we send the specimen to Gross for microscopy as in histopathological examination. Now it revealed that it had an encapsulated lesion with large cavernous vascular spaces, and it was hemorrhagic areas, fibrosis, and hyalinization. In this specimen, we can see the whitish area as the foci of calcification. Coming to differential diagnosis, after gross specimen microscopy, the possibility of a benign vascular tumor was considered. We can see in the image given alongside that this was the slide as seen in histopathological examination. The reparative processes which occur post FNSE could have contributed to the bloody aspirate, but we ruled it out by taking microscopy of the entire lobe. Definitive diagnosis, it was concluded as primary cavernous hemangioma of thyroid, which was achieved through the histopathological examination. As final diagnosis was achieved through histopathology, a retrospective analysis explained the blood aspirate in FNSE. So after histopath, we conducted a retrospective analysis which showed why blood aspirate was observed in FNSE. A rare possibility of vascular tumor should be considered if repetitive FNSE shows blood. Coming to management and intervention, surgery is the treatment of choice. Left hemithyroidectomy was performed in the patient. Diagnosis and was achieved by post-operative histopathological examination. I would like to summarize by saying that hemangiomas are common benign vascular tumors. Thyroid hemangiomas are extremely rare and considered to be a developmental anomaly, which occurs due to inavailability of the angioblastic mesenchyma in forming canals. Hemangioma should be considered in the diagnosis of any pulsatile organ, such as in this case is the thyroid. Thank you.
Well done. Can you classify hemangiomas?
Ma'am, hemangiomas are of 3 types as per what I have read. It is superficial, it is deep, and it is of mixed type.
And based on the source of the blood vessels or no, I won't say blood vessels, of the vessels.
Ma'am, no idea.
Okay, well done. You presented very well. Thank you.
So Pranjal, obviously the patient first came to you with the enlarged left lobe of the thyroid. So you would have done some serologies initially. So what serologies were done before you went ahead and did the FNSC and you sent the patient for surgery? Was some serological test done?
We conducted CT scan and MRI was done. And later we came to FNSC as it was an nodule was protruding in the neck. So we decided to do for an FNSC.
So any blood tests that can help? I know in this patient, obviously the diagnosis was made surgically, but so suppose you do find a nodule, what other serological tests would you do? Tests for antibodies so are these tests available?
So like in TFT, we usually do the thyroid antibody serum test. We can do that also, which is conclusive usually in Graves' disease. Besides that, the routine hematological investigations like CBC, platelet count, DLC were done.
Okay. Thank you, Pranjal.
Okay, thank you.
Thank you so much, Pranjal. It was really wonderful presentation and it was really up to mark. You can stop the screen sharing. Yeah, thank you. So now we have with us Shashank Reddy. Hi, Shashank.
Hello, can you see me?
Yeah, I could see you. You could just adjust your screen a bit.
Just a second.
Yeah.
That's fine now?
Yeah, it's fine.
Okay.
Your screen sharing. Yeah, your
you
PPTs. Yeah, the PPT is visible. Is the PPT visible to you, judges?
Yes.
Okay, so we will go ahead. Shashank, your time starts now.
Good evening, judges. My name is R. Shashank Reddy. Thank you for this opportunity to present my case of MASH metatarsal to metacarpal transfer for a hand tumor. A 25-year-old male clerk presented to us with complaints of swelling on the right hand, which was insidious in onset and gradually progressive, which was associated with dull aching pain and aggravated on lifting heavy objects. It caused difficulty for writing and holding objects, for which the patient consulted us. There was no history of fever, trauma, numbness, and swelling elsewhere. There was also no history of weight loss. There was no history of tuberculosis or similar lesions in the past. There were no, family members did not have similar complaints. On clinical examination, we found out on inspection that there was a solitary swelling, which was observed on the dorsolateral aspect of the hand. It was oval in shape, extending from the base of the index finger till half of the second metacarpal. Skin over the swelling was stretched. On palpation, there was no rise of temperature and tenderness was elicited. Also, inspectory findings were confirmed. Swelling measured around 6 centimeters to 5 centimeters, like shown in the image here. And then swelling was bony hard in consistency with distinct edge and smooth surface. Then range of motion was then tested. The normal hand had total active movements and total passive movements of normal ranges at the wrist and the metacarpophalangeal joints. But on passive movement of the right hand, that is the affected hand, metacarpophalangeal joint had a limited movement of around 10 to 60 degrees, normal being 0 to 9 degrees. And on active movement of the right hand, it was terminally painful. And this was expected, and it was due to extension lag. So other examinations were done where similar swellings were looked for and was not found. Examination of the lung, thyroid, and spine was normal, and axillary group of lymph nodes were found to be normal. Keeping everything in mind, we had a differential diagnosis of giant cell tumor, enchondroma, chondroblastoma, aneurysmal bone cyst, and tubercular dactylitis. Then we went on to do the investigations. Blood investigations came out to be normal. That is CBC, ESR, and CRP were normal. Radiography of X-ray of the right hand was done, followed by an MRI. A core biopsy was done to confirm. The X-ray showed osteolytic expansile lesions, which was geographic in distribution, with intact cortex on the second metacarpal extending from the distal epiphysis till the mid-diaphysis. It was polyostotic and gave a soap bubble appearance. It was lucent and hazy with septae in between. There was no periosteal reaction and no pathological fractures noticed. Core biopsy showed lobules of benign chondrocytes. To sum it up, there was a swelling on the hand with pain. It was solitary, hard, bony hard, and on X-ray it showed expansile intact cortex with biopsy of lobules of benign chondrocytes. So biopsy being the gold standard, we came to a diagnosis of enchondroma. Then an intervention was planned, which a curative intervention where excision was done, en bloc excision was done to make sure the tumor does not spill. And then excision biopsy was done to reconfirm our diagnosis, and lobules of chondrocytes were encased by reactive bone, which is very, very characteristics of enchondroma. For normal functioning, what we did was a reconstruction was planned. A matched metatarsal was harvested from the contralateral foot and was grafted to the recipient side. So the first picture showing here shows us after the en bloc excision, and that is on the right hand. And then the left foot was taken, the fourth metatarsal was taken to be precise. And then this shows the intraoperative images of the C-arm. After the en bloc excision, there was a defect, which was filled in by using the metatarsal, using plates and screws.
Actually, the time is up.
Time's up? Okay. These are the post-op X-rays, which showed union, and this is following physiotherapy. My message would be that using this novel technique, this was life-changing for the patient. Otherwise, it was managed through amputation. So it gave good hand function and donor side mobility. Thank you so much for this opportunity, judges. These are on the record.
Shashank, very well presented, very clear presentation. I really don't have any questions.
So I would introduce.
Shashank, please stop the screen share. Yeah.
Yes.
Very well done. Why did you take the contralateral foot?
Ma'am, it is actually, that is done because of the curvature of the bones, ma'am. So when we can, if I could show you the picture, it would be more clear. So the curvature of the bone, so like we can see in embryology, the limb, the upper limb is rotated front, while the lower limb is rotated in the opposite direction. So that becomes a better graft.
Okay. Yeah, stands to logic. Thank you. Well done.
Yes.
And very innovative, I must
Thank you
say.
so much, ma'am. Thank you.
Thank you, Shashank. It was a really interesting case and it was really wonderfully presented. Yeah, so thank you. Now we have with us Radhika Van.
Yeah, just a minute.
Yeah, hi Radhika.
Hi.
Yeah, you're visible.
Yeah, is the screen visible?
Not yet. Yeah, now it's visible.
Okay.
Okay. Judges, can you see the presentation?
Yeah.
Okay. So we will begin now. Your time starts now, Radhika.
Okay. Good evening. My case is Neuroleptic Malignant syndrome. A 24-year-old male student presented to the casualty in a tuberous state with altered sensorium, active pupils, and hypothermia. He was not responsive to verbal and painful stimulus. Vitals were recorded. NG tube and Foley's catheter was secured, and gastric lavage was given in suspicion of consumption of an unknown poison, along with unknown time of consumption. On questioning the patient's relatives, the patient had consumed 20 tablets of olanzapine, 10 mg, prescribed to him by a psychiatrist. On further questioning, a conflict with the father was found to have preceded the action taken by the patient. He was a known alcoholic with history of episodic binge drinking. However, the last episode of drinking remains uncertain. No prior such incidents were noted in the patient's history. No past medical or surgical history was noted. No history of psychiatric illness in the family was noted. Patient had recently been involved in an interpersonal conflict for which he had apparently taken a psychiatric consultation in view of his depressive tendencies and fragile mental status. Clinical examination. The rectal temperature was alarmingly high. It was 104 degrees Fahrenheit on day 1 and gradually reduced to 97.6 degrees Fahrenheit. The pupils were sluggish on the first 2 days. GCS was E1, V1, M4. Plantar reflexes were of extensor type and clonus was absent. Reflexes were diminished on all 4 days, being 1+ on the first 2 days. The patient had hypertonia. Diaphoresis was present on the first 2 days. The CBS and RS examination was normal and bowel sounds were sluggish. The CBC, fasting blood sugar and AG ratio was normal. On day 1, the pulse rate was 150 per minute, blood pressure was 170 over 100 mmHg, and respiratory rate was 26 per minute. All these 3 readings reduced gradually over the next 4 days. Investigations. To rule out any organic brain pathology, an MRI with angiography was done, which was normal. Chest X-ray was normal. ECG showed sinus tachycardia with variable heart rate on admission. Differential diagnosis. Infections like meningitis, encephalitis, brain abscess. Neurological conditions like non-convulsive status epilepticus, septic encephalopathy. Toxins like substance abuse, amphetamines, cocaine, alcohol withdrawal. Endocrine causes, thyrotoxicosis and pheochromocytoma. And environmental causes like heat stroke were ruled out. Furthermore, hypothermia syndromes like serotonin syndrome, anticholinergic tox syndrome, and malignant hypothermia were also ruled out. Patient analysis. The consumption of multiple tablets of olanzapine made him land in a more likely case of hypothermia and dysautonomia. The de novo presentation after consumption of this nature of antipsychotic first time in such a high dose made him a vulnerable candidate for neuroleptic malignant syndrome. So the final diagnosis was neuroleptic malignant syndrome. The treatment was, the patient was shifted to the ICU in a comatose state. Tablet nifedipine 20 mg was given. External cooling measures like administration of cool saline and cool sponging was done. Despite all the cooling measures, the patient had persistently high temperature of 102 degrees Fahrenheit with labile blood pressure
1 minute left,
suggesting marked dysautonomia. The renal parameters were well preserved with no significant alternation in the urine output or any gross hematuria or myoglobinuria. So the patient's primary treatment was observing the vitals and continuous monitoring, where the main concern was reducing the hypothermia and dysautonomia. Thank you.
So Radhika, very well presented, clear case. What do you think is the long-term outcome for this patient? As far as counseling is concerned, what all would you advise this patient now?
Sir, we'll carry on with the medical therapy till the patient goes back to normal state. So the course of treatment is approximately 14 days. And once all the parameters, they're back to normal, that time we start him on CBT, and well-monitored antipsychotic therapy can be given to supplement.
So are there some specific drugs that are perhaps safer that you would use in preference to some other drugs?
So dantrolene is used
for antipsychotic. Sir, some the atypical antipsychotics, they are safer. Sir, olanzapine is supposed to be a safe drug, but because he overconsumed it, that's why there was a chance. That's why he developed a neuroleptic malignant syndrome. So apart from that, there is risperidone.
Quetiapine is also used.
And is there a metabolic basis for the condition? For this condition, is there what is the basis for why this happens?
So this is mainly because of the overdose of olanzapine, and there's also a genetic basis.
So what's the basis?
Yes, sir. So what happens is that this is a dopamine antagonist. So because apart from that, it is also, there are other receptors which it acts on, like the alpha receptors. So because there's a downregulation of dopamine receptors, there is a state of hyperthermia. And because it acts on alpha receptors, there is hypertension that's been seen in this condition.
Okay, thank you. Thank you very much, Radhika.
Thank you, sir.
Well done, team, Radhika. Okay, what do you mean by dysautonomia?
It's a condition where basically the autonomic nervous system, it's a dysregulation of the autonomic nervous system. So there's urinary incontinence and.
So what is the basis of that?
High blood pressure.
What is the basis of that?
Oh yeah. Thank you, ma'am, for your question. Ma'am, so the basis of this, again, as I mentioned, is because there is overactivation of the alpha receptors, that's alpha-1 receptor, alpha-2 receptor. So that causes tachycardia and marked hypertension. So that is the basis of dysautonomia in this condition.
So there is an imbalance between the sympathetic and the parasympathetic. Are you trying to say that?
Yes, ma'am, there is an imbalance between the sympathetic and parasympathetic because of overactivation of the sympathetic system.
Yes, that's what I wanted. That was the answer I was looking for. Well done, team Radhika.
Thank you.
Thank you, ma'am.
Thank you, Radhika and Ruchi. It was really a great presentation, and it was really up to mark. So now we will move ahead. We have Rajvi Rao with us. Hi, Rajvi. Hi. Can you share the PPT, Rajvi? Could you just unmute yourself? You're not audible. Am I audible now? Yeah, you are audible now. And your PPT is also visible. So just can you see the PPT?
Yes, yes. Absolutely.
Okay. So you can start, Rajvi. Your time starts now.
Very good evening to everyone. I'm an intern doctor at PDU Medical College, Rajkot. I'm here to present a case of paraduodenal hernia for author 23rd. A 35-year-old male patient, uneducated and working as a farmer at Amreli.
Rajvi, you have two devices on because there is an echo coming.
Yes, Rajvi. I guess you have joined from two devices.
May you put your video off, just speak without the video.
Okay. Hello, is the echo better now?
More, yeah, maybe more clearer now.
Okay,
but it's present still there.
Still there.
But okay, you could go. You can go ahead.
Go ahead. Yeah.
Okay, should I start again or should I just continue now?
Just continue.
Okay. A 35-year-old male patient, uneducated, working as a farmer at Amreli, presented as an emergency case at Rajkot Civil Hospital on 14th May. With the chief complaints of abdominal pain with tension and vomiting since 2 days. The patient was The onset of pain was insidious and dull-aching in nature. The pain was moderate, persistent, and gradually progressive. It was paramedical initially and then became diffused over the generalized abdomen. It was not radiating, not recurring, and aggravated on straining and intake of food. It was associated with 10 to 20 episodes of non-projectile, non-bilious vomiting with gastric content. It was not bloodstream or foul smelling. And he did not pass food or platters since the onset of abdominal pain. He used to have similar episodes of mild abdominal pain in the past, which were self-limiting. The patient has no history of abdominal trauma, fever, bleeding, or mucus discharge for rectum. Patient's medical history, operative history, family has no significant positive finding. The patient is vegetarian by diet with decreased appetite and sleeps since last 2 days and has had observation for 2 days, whereas the bladder habits were normal. He is addicted to smoking BD for 15 years. On general examination, patient showed some signs of dehydration. On per abdominal examination, the abdomen was distended with central umbilicus. There was no visible peristalsis. There was generalized tenderness on palpation and hypoperistaltic bowel sounds were heard. The abdominal circumference of 87 centimeters was noted. Rectal examination and other systemic examination revealed no positive findings. All hematological investigations were within normal limits and with slightly leukocyte count. Plain X-ray of the abdomen in erect posture revealed loops of small bowel distended with the air fluid levels mainly on the right half of the abdomen. The USG abdomen showed the maximum diameter of the dilated bowel to be 2.5 centimeters. The CT scan revealed focal clumping of proximal jejunal loop just distal to the duodenal jejunal junction, the left paramedial location along the supraumbilical aspect, with superior mesenteric artery lying anterior to superior mesenteric vein lying anterior to the superior mesenteric artery, suggesting the possibility of malradiation internal hernia. So, on basis of this, the diagnosis of acute intestinal obstruction due to internal hernia was made. The patient was kept NBM and conservative management was done. Diagnostic laparoscopy was done in which left paraduodenal hernia.
Rajvi, 1 minute left.
The left paraduodenal hernia was identified. It was then converted into an open laparotomy to reduce the herniated bowel loops and for the ligation of the mesenteric arms. The pelvic drain was placed and the next closure was done. The post-op period was uneventful and the patient was discharged after 5 days. So the inference that we derive from this is that paraduodenal hernia is the most common form of internal hernia, and 0.2 to 0.9% of all cases of intestinal obstruction are of paraduodenal hernia. The left paraduodenal hernia specifically is a congenital anomaly formed during midgut rotation that leads to herniation of small intestine between inferior mesenteric vein and posterior parietal attachments of the descending mesocolon to the retroperitoneum. The space into which the bowel herniates is called the porta of Lansard. The clinical presentation can vary from asymptomatic to non-specific symptoms, and the diagnosis is mainly based on history, clinical examination, CT scan. The operative challenge here is to weigh out the risks and benefits of the laparoscopic approach in comparison to open laparotomy, after considering the possibility of adhesion, perforation, and injury to important vessels.
Rajvi, timer.
So Rajvi, very well presented, very clearly presented. So what is the likely long-term course for this patient? Obviously you have repaired the hernia. Could there be problems on the long term, complications of surgery or a likelihood of recurrence or so on?
Yes, sir. There have been cases of recurrence being noted in case of paraduodenal. However, that is the focus that we try to show through this presentation. That if we are repairing the paraduodenal hernia based by a laparotomy versus the laparoscopic approach, then in laparotomy, because we naturally forming the adhesion are more, hence the plication of mesenteric sac would be much better in comparison to if we were to reduce and manage the same hernia case through laparoscopic measure.
Okay, thank you.
Well done. This thing, how rare is this presentation?
So, ma'am, hernias, internal hernias form about, like I said.
Actually, just put off your video. Just put off your video because your audio is not working well. So can you just put, now you can respond.
Yeah, so they so overall is from like I said 0.2 to 0.9 the total value. And further, the left-sided parotidal hernia is much commoner in the right parotidal.
Okay, thank you.
Thank you, ma'am. Thank you, sir.
Thank you so much, Rajvi. It was really a good presentation. All the facts were really up to mark. Thank you. So let's move ahead, and we have our next participant, Samarth Habu. Hi, Samarth.
Hello, good evening, Arya.
Good evening.
Am I audible?
Yeah, you're audible. Can you share the PPT, Samarth?
Yeah, sure.
Yeah.
Is my screen visible, Arya?
No. Now it's visible.
Hello. So can I start?
Judges, can you see the PPT? Yes, judges can see the PPT. Samarth, you can start. Your time starts now.
Good evening, one and all. This is Dr. Samarth Habu, House Surgeon at Bangalore Medical College. So here I am presenting a case of patient, female patient by name Mrs. XYZ, 24-year-old, wife of Mr. ABC, 28-year-old, homemaker by occupation, belonging to upper lower class of socio-economic states. She comes with a chief complaints of abdominal pain for the past 2 days. Her history of presenting complaints, she's a 24-year-old lady, present with 4 months of amenorrhea, presents with lower abdominal pain, sudden onset, no radiation, no aggravating or relieving factors. There is no history of bleed per vagina, or no history of impending size like headache, visual disturbance or swelling of legs. Obstetric history, married life of 4 years, non-consanguineous marriage. She is gravid to para 1 living 0. Her last menstrual period was 17th of May 2021 and her expected date of delivery is on 24th of February 2022. She is 16 weeks, 2 days period of gestation. Past pregnancy was at the first pregnancy at the age of 20 years of age. Cesarean section was done in view of cephalopelvic disproportion. Antenatal, natal and postnatal events were uneventful, but baby died at age of 1.5 years due to a cardiac disease. Present pregnancy was detected at UPTY at home. First dose of tetanus toxoid were taken. Routine investigations were done and USG scan were told to be normal. There is no excessive history of excessive vomiting, radiation exposure, fever with rash or any drug intake. Her menstrual history, she attained menarche at 13 years of age. She had a 3 to 4 days of bleeding and 30 days of the cycle. Uses 2 to 3 pads per day. No passage of big clots and not associated with pain abdomen. There is no significant past history, family history, or personal history. So summary, 24-year-old, gravid to para 1 living 0 with 16 weeks, 2 days period of gestation. With previous LSCS, came with chief complaints of pain in lower abdomen since 2 days with no associated symptoms. On examination, moderately built and nourished, conscious, cooperative, and well-oriented time-present person was examined with a female attendant, adequate privacy. There was no pallor, ictus, cyanosis, clubbing, edema, or lymphadenopathy. Her vitals were 37 degrees of temperature was 37 degrees centigrade. Pulse rate was 95, respiratory rate was 15 cycles per minute, her BP was 130/70 mmHg, thyroid, breast and spine examination revealed normal findings. Systemic examination also, CVS, RS and CNS findings were normal. Per abdomen findings, inspection, abdomen was distended more on the right side, umbilicus was normal, Lesion, IGRA was and Shia albicans were present. Previous cesarean section scar present at 2 stents at suprapubic transverse 10 cm healed by primary intention. There was no history of no visible peristalsis, no engorged veins or visible pulsations, and hernia intact. And on palpation, there was tenderness present in the right iliac fossa, no local rise of temperature, felt more in the right iliac fossa. Percussion, no evidence of free fluid in the abdominal cavity. Auscultation, bowel sounds were heard. A local examination, birth cycle done by a senior duty doctor. Cervix was bluish discoloration, and per vaginal examination revealed tenderness present in the right fornix, fullness in the right fornix, and cervical motion tenderness was present. So diagnosis is 24-year-old female patient, gravid to para 1 living 0 with period of gestation 16 weeks 2 days with previous LSCS with query of abortion of ectopic pregnancy. Routine investigations were normal. HB was 11 gram percent. Her serology tested negative. So on USG revealed endometrial thickness of 6 millimeter and evidence of gestation sac with corresponds to 15 weeks days of period of gestation, which was present in the right adnexa, and impression was an ectopic pregnancy in the right adnexa, mostly tubal origin. So these are the USG findings. I would like to make a note. So after taking consent and routine preoperative investigations, we took the patient for emergency laparotomy. On laparotomy, bicornuate uterus with the pregnancy in right non-communicating horn, which was unruptured, 50-gram clot was present in the intraabdominally. Right cornu containing ectopic was resected with right salpingo-oophorectomy, and 1 unit of PRBC was transfused. So this is the picture showing the right non-communicating horn. In order to show the communication, we do methylene blue, which was a non-communicating horn between the right horn and the vagina. So this is the case of bicornuate uterus in a non-communicating rudimentary horn.
So
in incidence is 1.
Time is
so okay, fine. Sperm has, there is a transperitoneal migration of. Thank you.
Samath, could you start your video at least for the
Yeah,
Q&A
sure.
session?
Am I visible?
Yeah, you are visible. Go ahead with the Q&A session.
Yeah, well done, Samarth. Very interesting. How frequent is this occurrence?
Ma'am, ectopic pregnancy in a bicornuate uterus studied by one of the Kumar et al. Showed that incidence is 1 in 76,000 to 1 in 150,000.
Oh, can this lady get pregnant again?
Yeah, yes, ma'am. Prophylactic resection of right horn, rudimentary horn was done, ma'am. So she can undergo, but in the next pregnancy should be in a tertiary care center with a cesarean section should be taken in the tertiary care hospital.
Okay, good. Thank you.
Thank you.
So, Samarth, can these pregnancies ever go to term? Suppose you were to remove this fetus, can this be reimplanted again? You know something. Is there anything new in this regard?
Sir, generally in ectopic pregnancy in the rudimentary horn, generally they present at they are more prone to undergo rupture at 12 to 16 weeks, sir. So generally ectopic pregnancy cannot have a very bad prognosis, sir. Only secondary abdominal pregnancy can go till term and can deliver, but very rare or to find a ectopic pregnancy in a horn non-communicating horn to deliver.
Okay. So can there be any reports, wherein they have explanted the fetus into the main intrauterine cavity? Is that?
Sir, in the ectopic pregnancy of a non-communicating horn, I'm not that aware, sir. But there are case report and literature which shows that abdominal pregnancy, abdominal ectopic, secondary abdominal ectopic, they have been delivered at the term, sir.
Okay. Thank you. Thank you so much.
Thank you so much. Thank you so much, sir.
Very clear presentation. Thank you.
Thank you so much.
Thank you so much, Samarth. It was really wonderful presentation by you. Thank you. So now we have with us Shreya Bora. Hi, Shreya.
Am I audible?
Yeah, you're audible. Even you are visible. Can you share the PPT, Shreya?
Hey, band.
Samarth, could you mute yourself?
Yeah, conference seva open.
Samarth, could you mute one second? Yeah, Shreya. Yeah, your PPT is visible, Shreya.
May I start?
Yeah, you can start.
Good evening.
Starts now.
I am Shreya Bora from BJMC and Sasan Hospital, Pune. I am currently studying in second year MBBS, and I would like to discuss with you all a case on E-cyst arising from Gerota's fascia of kidney. A 40-year-old female, non-hypertensive, non-diabetic, came to the OPD with a chief complaint of lump in the abdomen. She was apparently all right 1 year back when she noticed a small lump in the right side of the abdomen. She ignored it initially, which gradually increased, associating itself with a dull, non-radiating pain. Family history was insignificant. Past and personal history included tubal ligation 8 years back, and the patient had no addictions or any major illness or surgery in the past. Patient was examined with due informed consent in a well-illuminated room. The patient was well-oriented to time, place, and person, afebrile with a normal pulse and blood pressure, no pallor, icterus, cyanosis, clubbing, pedal edema, or lymphadenopathy. The patient was exposed from nipples to the mid-thigh with due informed consent for the abdominal examination. Under good illumination, the lump showed no pigmentation, inflammation, evidence of any scarring, sinuses, or ingot veins. The lump was an ovoid mass of approximately 25 to 20 centimeters square, and the umbilicus was seen to shifted
to have shifted laterally to the left and inferiorly of its normal position. Knee-elbow position was attempted in the patient, but due to a massive size, the origin could not be made out. Here we can see that the lump is occupying almost all of the right hemiabdomen. On palpation, there was no local rise in temperature. The lump was non-tender, extending from right costal margin to the inguinal ligament and crossing over to the other side of the midline. Bosculated surface with well-defined margins, firm consistency, restricted mobility, and bimanually palpable. On percussing, dull note was heard and no evidence of free fluid was noted. On auscultating, normal bowel sounds were absent on the right side at the site of the lump. Per rectal, per vaginal examination did not give any significant findings. Examination of cardiovascular, central nervous, and respiratory systems showed no detectable abnormality. Provisional differential diagnosis was made. Further investigations were done. Ultrasonography revealed a large solid abdominopelvic mass of neoplastic etiology. CECT revealed a 18 by 21 by 27 centimeter cube size, heterogeneously enhancing hypervascular, well-defined soft tissue density lesion in the retroperitoneum. And finally, a CT-guided true-cut biopsy was done showing benign spindle cell lesion. Clinical differential diagnosis narrowed down to a retroperitoneal tumor, most likely a GIST or a neurofibroma. Decision was taken to do an exploratory laparotomy. The retroperitoneal mass was resected along with the Girota's fascia of the right kidney. No post-op complications were reported. Final histology report after IHC markers confirmed the diagnosis of benign E-GIST from the Girota.
1 minute left.
Tumor dimensions and the weight was noted. The patient was followed up for a frequency of 3 months for a year, and PET CT scan did not show any recurrence. GISTs are very common mesenchymal tumors. The discovery of mutation of KIT was very fundamental. GISTs have been documented in all parts of the GI tract and are unrelated, and also an unrelated tubular gastrointestinal tract called E-GISTs. Gastrointestinal GISTs represent less than 1% of all the malignancies. 10% of these GISTs are your E-GISTs, and E-GISTs arising in the retroperitoneum are very rare, such that only 58 cases have been described in the English medical literature. The objective of reporting this rare case was to discuss its clinical behavior and the treatment. The references for the same. Thank you.
Shreya, very good, well presented. Shreya, can this patient have a recurrence somewhere else?
Sir, it was definitely after the IHC report, it was very it was confirmed that it is a benign tumor, but definitely if it would have been a malignant GIST, then there are a lot of places like the smooth muscle where it could have like the recurrence would have been noticed.
But and were you able to do genetics in this patient? Were you able to do genetic studies here? Genetic studies, were they possible?
Genetic studies were not made, but definitely we could have gone ahead with it. But I'm not aware of how to go about it.
Okay. Thank you, Shreya.
Thank
well
you,
done, Shreya. See, when you're looking at a tumor, neoplastic tumor, there are two ways it can occur at different sites. One is if it's a malignant tumor, what else can it be? That you can get multiple lesions in the body.
Can I take a guess?
Yeah, of course.
Ma'am, could it be in a very fastly replicating tissue, like the epithelium tissue, where you can see multiple places where the tumor is arising? For example, neurofibrosarcoma.
Okay. In a way, you are right. If you're looking at a multifocal lesion, so de novo arising in different tissues. So that is one, I think that's what Dr. Arvind was also trying to get at, that it could be a secondary, from a primary if it's a malignant tumor, or the lesion could be multifocal like you have in neurofibromas. It's not necessary it's malignant, but you have multiple lesions in different parts of the body because the lesions are multifocal.
Right.
They develop de novo at different sites. Yeah. Well done, Shreya.
Thank you, ma'am.
Thank you, Shreya. It was really great presentation. All the facts were really interesting. Thank you so much.
I had a good time. Thank you.
Thank you. So now we have with us Sneha. Hi, Sneha.
Hi.
Hello. So can you share screen the PPT.
Is it visible?
Yeah, it's visible. Judges, can you see the PPT?
Yeah.
Okay. Sneha, you can go ahead. Your time starts now.
Okay. I'll be present. Good evening, everyone. I'll be presenting a case on bilateral phyllodes tumor in a 12-year-old premenarchal adolescent. I'm the author Sneha Kenjale, and Devang Gode, Dr. Sajida Dige, and Dr. R.K. Shinde are the co-authors. I present to you a case of a 12-year-old adolescent premenarchal female who is a student, Hindu by religion, resident of Nagpur, belonging to a low socioeconomic status, who came to OPD with her parents with chief complaints of bilateral enlargement of breast since 1 year and pain since 15 days. As narrated by the patient herself and her mother, she was apparently all right 1 year back when she noticed a movable lump, first in the right and later 1 month later in the left breast while bathing. It was insidious in onset and rapidly progressive in nature. The lump in the right breast was first felt in the upper lateral part, and in the left breast, it was first felt behind the nipple, that is in the retroareolar region. Its size progressed rapidly such that it was of size 2 into 3 centimeters to begin with, and now it is of size 8 into 10 centimeters that involved whole of the breast tissue. The lump was painless initially, but became painful since 8 months. She experienced dull aching pain, which was occasional and was localized, mild and non-radiating. There was no history of trauma, discharge or ulceration. There's no history of retraction of nipple, no history of swelling in axilla, neck or abdomen, no history of loss of weight, appetite or any history suggestive of metastasis was not present. There was no history of asthma, TB, diabetes, no history of any surgical intervention or previous drug intake. No history of breast, ovarian, colorectal, stomach or pancreatic cancers in first or second degree relatives. Her personal history is normal. She did not attain her menarche yet. The pain worsened since 15 days, and because of which hampered her daily activities like changing clothes, bathing, following which she approached her hospital. On general examination, her vitals were normal. Her Karnofsky performance score was 70. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy or edema. Her systemic examination was normal as well. On local examination, on inspection, the bilateral breast enlargement was noted, which was asymmetrical. Nipple on the right side was a little bit higher as compared to that of the left side. There was no crack, fissure, or discharge from nipple. Areola of the right side was without any cracks, fissures, oozing, or redness, whereas on the left side there was distraction of the nipple areola complex. There was no cracks, fissures, or oozing on that side too. Breast asymmetry was appreciated on both the sides. The lump involved whole of the breast without any puckering, dimpling, ulceration, or fungation of the breast. Skin over the breast appeared to be tense without any engorged veins. On raising hands above the nipple, above the head, right nipple was at the higher level than the left, and arm, thorax, supraclavicular fossa appeared to be normal. This is how the bilateral enlargement of breast was seen. On palpation, local temperature was raised with marked tenderness.
Neha, 1 minute left.
Yes. On palpation, size of the lump was 7 into 6 centimeters, which was almost same on both the sides, and there was no other swelling in axilla, cervical, or any other side. These were the differential diagnoses which were offered. USG breast revealed heterogeneous hyperechoic lesion, and FNEC showed a hyperplasia of mammary stroma and epithelial cells. Here in tissue biopsy, we can see that there is this leaf-like pattern seen, which gave us the definitive diagnosis of phyllodes tumor, and there was less mitotic figures, because of which the diagnosis was benign bilateral phyllodes tumor of breast. A treatment we offered was simple mastectomy.
Neha, time up.
Yes. Okay, thank you.
You can begin with the Q&A session, Sneha.
Sneha, very good, clear presentation. So what's the long-term outcome going to be here? Given that do you think that this is a benign tumor?
Yes.
No, you saw, so what do you thought? Any specific things that you want to counsel the child?
Yes, sir. Because the treatment was only surgical treatment, which we can offer in this case, as phyllodes tumor has fear of recurrence. So after this, herself and her parents was counseled about breast reconstruction surgery, which will be, and parents agreed to it, which will be done after she attains her menarche, after like 1 to 2 years after she attains her menarche. So we'll be doing breast reconstruction surgery on her so that her quality of life is improved. And follow-ups were done so that to see whether there is recurrence of the phylloid tumors or whether there is any metastatic changes.
Okay, thank you. Thanks.
Sneha,
yes, ma'am.
How rare is this? And how did you clinically make it, because one of your differentials was bilateral phylloids. How did you think of phylloids?
Yes, ma'am. Actually, looking at the age of the patient, carcinoma was not that much suspected. We suspected giant fibroadenoma, phyllodes, and virginal breast hypertrophy. So we went further with the investigations. USG and revealed hyperechoic lesions, which was
clinically, how common is it that you normally think of common things, So how
Yes.
of the 3 differentials you considered, which is the commonest?
Sir, ma'am, the commonest one was looking at the age was giant fibroadenoma because
that's what I thought.
Yes,
and is that a bilateral tumor?
Yes, ma'am. It's a bilateral tumor, bilateral phyllodes tumor.
Okay, thank you.
Yes.
Thank you, Sneha. All the facts and were put forward really well. It was a really interesting case. Thank you to have you. So now we have our next participant. It's Tejaswini Jagtap. Hi, Tejaswini.
Hi.
Hello. Your video is not visible, Tejaswini.
Okay. Can you see the screen now?
Yeah, the screen is visible. The screen is visible. Yeah. Please share your PPT. Yeah, it's visible. Judges, is the PPT visible to you?
Yes.
Okay.
Tejaswini, go ahead. Start with your presentation.
Good evening, judges. Today I present before you a case of young male with chronic intractable diarrhea. A 41-year-old male came to the OPD with the chief complaints of loose motions, pain in abdomen, generalized weakness since 1 month. He experienced 10 to 15 episodes of loose motions per day, which were non-pulse smelling, watery to semi-solid in consistency, having undigested food particles with nocturnal frequency and post-meal urgency, with borborygmy and without blood or mucus in it. The loose motions were not aggravated by wheat or milk intake. Patient has history of chronic loose motions on and off since 2 years. There was no history of recurrent respiratory, urinary, or any other infection, no history of promiscuous behavior and significant travel history. He did not respond to multiple antibiotics use and abstaining of wheat and milk and was further evaluated for immunodeficiency syndrome. On examination, mild pallor and edema was seen. There was no dermatitis hepatiformis and his weight was 62 kg. The abdomen was soft, non-tender, and the bowel sounds were heard in all the 4 quadrants. The rest all systems were normal. On investigation, hemoglobin and platelet were found to be reduced. Liver function and the renal function was normal. Vitamin B12 and ferritin was also normal. Thyroid function was normal. Anti-HCV and HIV, anti-HBsAg were negative. Stool examination, both culture and microscopic, was also normal. Urine examination was normal. USG CT abdomen showed no significant findings. Colonoscopy was also normal. On ogiriscopy, duodenum showed fissuring with nodularity as seen in the video.
Hello, Tejaswini. We can't hear you.
Yeah. Further, a duodenal biopsy was taken, which showed focal venous atrophy with crypt hyperplasia and dense lymphocytic infiltrate with plasma cells and few eosinophils. Lymphoid follicles were seen in lamina. Intraepithelial lymphocytes 8 to 9 per 100 enterocytes with decrescendo pattern were seen. No Giardia or any other parasite, granuloma, or feature of irritable bowel disease was seen. Further, immunoglobulins were tested, which showed low levels of total serum IgG, IgM, IgA, and tissue transglutaminase IgA was negative. After ruling out the above differentials, a final diagnosis of common variable immunodeficiency syndrome associated with enteropathy was made. In virtue of the above diagnosis, the patient was started on the course of IVIG 400 milligram per kg dose spread over 4 days along with antibiotics. The patient was also advised to avoid wheat and milk. Apart from the fact that it is estimated to affect 1 in 25,000 individuals, what made me take up this case was that CVID is an immunodeficiency disorder. Yet majority of patients showed autoimmune manifestations. This behavior of immune system is not clearly explained, and further research would open doors of understanding function of immune system. Another interesting thing is that when it is a familial case, it is inherited majorly as an autosomal dominant disorder. Yet 10%, less than 10% of family members are affected, or they have the dominant gene but not the obvious disease. These are my references. Thank you.
Tejaswini, thank you for a very nice and a pictorial presentation. Tejaswini, what about genetics here? Did you look for genetics for CVID? The causes of the genetic causes of CVID.
Actually the thing is we could not look for the genetic because the facility was not available. But there are some of the genes that had been discovered, like ICOS, and as far as I know, ICOS is one of the genes that has been discovered to cause genetic CVID.
And is it usual, to just have a history of diarrhea that begins almost very late into much after adolescence with no other findings, with no respiratory symptoms, nothing, Is it a usual presentation of CVID?
Sorry, sir.
Is it common to have such a late manifestation with no other symptoms, with no other infections? How common is it?
It is not really very common. With just the GI symptoms, only less than 17% of the patients show with the GI symptoms, and the case like this is found only in 1 in 25,000 individuals.
Did you confirm the IgG levels again, or you just did it once?
We confirmed the IgG levels again.
They were still very low.
Yeah.
They were still low. Okay, all right. Thank you.
Thank you.
Well done, Tejaswini. Why did you look for dermatitis herpetiformis?
To rule out the celiac disease. If there is any sign of dermatitis herpetiformis, so that will include celiac disease if it was seen.
Okay, well done.
Thank you, Tejaswini. It was a really wonderful presentation, and the facts were really up to mark. Thank you. So now we have with us, just a second. Okay, sorry. So we now have with us Vaishnavi Singh. Hi, Vaishnavi.
Yes, ma'am.
Hi. Your video is not visible.
Yes, ma'am. Just a minute.
Yeah. Arvind sir and Neena ma'am, I feel we will go over the time like for 15-20 minutes. I hope it's okay with you.
Yeah.
It's okay. Yeah. Carry on.
Hi Vaishnavi, can you share your screen?
Is it visible, ma'am?
Yeah, your screen is visible. Judges, can you see the screen?
Yes, yes, we can.
Okay. Vaishnavi, you can start.
Yes, ma'am. Just a moment. Good evening, esteemed member of the jury and the host of the event. I am Vaishnavi Singh, a final year student of School of Medical Sciences and Research, here to present a case study on patient with COPD, tuberculosis, fungal infection, and hydatid cyst. My patient, Mrs. Panveshwari Devi, is a 77-year-old female presented to the respiratory medicine OPD with complaints of shortness of breath, chest pain, and cough for 1 year. Shortness of breath increased on exertion. Her chest pain is gradual in onset, bilateral and diffuse. It is non-radiating. Cough is non-productive and persists throughout the day. There is no postural or diurnal variation observed. She is a chronic smoker and she smokes approximately 5 to 10 BDs per day, and she has been smoking for more than 30 years now. There is a history of biomass fuel exposure too. Moving to clinical examination, patient was examined in a well-lit room. Patient was conscious and oriented to time, place, and person. The vitals recorded at the time of examination is shown in the table. We can see her respiratory rate is elevated, which is 22 breaths per minute. All the other vitals are within the normal range. Pallor is present and there is no icterus, clubbing, cyanosis, lymph node enlargement, and edema. Now, moving to abdomen examination, we can see there is no abnormal finding on inspection. Superficial palpation revealed localizing temperature in the right hypochondrium area. On deep palpation, diffuse tenderness was observed in the right hypochondrium area. Now, normal bowel sound are heard on auscultation. Coming to chest examination. On inspection, the trachea is centrally placed, chest wall is cylindrical in shape and bilaterally symmetrical. Movement is seen with respiration and it is decreased on the right side. There is no scar mark or distended vessel observed. Palpation, there is decreased chest wall expansion on the right side. Normal resonant sound is heard on percussion. There is decreased breath sound on right side, decreased air entry on right side, increased vocal resonant and vocal frequencies on auscultation. The cardiovascular and central nervous system are normal. Moving on to the investigations, we can see her hemoglobin level is depressed and the normal range is given for the reference. Her random blood glucose level is slightly elevated. In her DLC, we can observe there is mild increase in neutrophil and markedly depressed lymphocyte level. Her kidney function test, liver function test, and thyroid function test are all normal. She is negative for HIV, hepatitis B and C. Urine culture and sensitivity revealed the growth of E. coli colony, which was found to be sensitive to the drug shown. Ultrasound of abdomen revealed multiple anechoing cysts in liver, which suggested hydatid cyst. Here's the ultrasound. Multiple well-defined hypodense lesions is observed in both lobes of liver or non-contrast and contrast-enhanced CT of abdomen.
Vaishnavi, 1 minute left.
Yes, ma'am. On chest X-ray, patchy consolidation with cavitation is seen on upper lobe of the lung. Sputum CBNAT, microbat MTB is detected and which is sensitive to rifampicin. Bronchoscopy revealed a black mass in right apical part of lung. BL was done for CBNAT and galactomannan. Tissue sample was sent for histopathological evaluation and fungal growth. Tissue fungal culture is negative for fungal growth. Galactomannan is positive for fungal growth. KOH mount revealed pseudohyphae. She is diagnosed with anemia, pulmonary TB, COPD, fungal infection, hydatid cyst, and UTI. Now, management and intervention. Firstly, the anemia is corrected by blood transfusion. 2 units of blood has been transfused. Her status is improved drastically. Patient is treated with tablet albendazole for multiple cysts. Capsule itraconazole is given for fungal growth in her lungs. Anti-tubercular for pulmonary.
Vaishnavi, time up.
Yes, ma'am.
Yeah.
So Vaishnavi, complex case that you have presented with. Vaishnavi, you said galactomannan was positive. So which fungal growth do you get a positive galactomannan?
Sir, it could be due to aspergillosis.
So why did you say aspergillosis? Why do you have to call this fungal growth alone? So clearly there is given that because galactomannan will not be positive anywhere else.
Sir, actually we could not cannot do further evaluation on her because she requested for discharge.
I can't hear you well. Yeah. Sorry. Yeah. Can you just speak out again?
Sir, yeah, actually, I was saying that, sir, it was not affirmative. Like, patient did not cooperate for further evaluation. So we could not do it on her. She demanded for her discharge.
Can we do anything on the blood in a suspected aspergillosis patient?
Sir, I cannot hear you.
Can we do anything else in a patient with suspected aspergillosis? Something that you can do on the blood. Can you do a blood test as well?
Yes, sir. Amphotericin B is injected.
No, a blood test for diagnosing aspergillosis.
Sir, antigen can be detected from her blood.
Okay, all right. Thank you.
Sir, sir, I would like to add.
Yeah.
Sir, IgG levels are monitored.
IgG levels against what?
Sir, against the organism of galactomannan.
Okay, all right. Thank you.
Aspergillosis.
Thank you. Thank you.
Thank you, sir.
You said pseudohyphae was seen, no?
Yes, ma'am.
So does aspergillosis give rise to pseudohyphae?
No, ma'am.
You're not audible, Vaishnavi.
Ma'am, no. I'm saying no. Pseudohyphae is not seen in aspergillosis.
Which fungus is pseudohyphae then seen in? And why did you make a diagnosis of aspergillosis?
Ma'am, actually, it was inconclusive. So pseudohyphae is can be seen in Candida species.
Okay.
So this is why it was very inconclusive about her. So empirically, we treated her with itraconazole.
So which fungus would that cover?
Pardon, ma'am?
Which fungus would itraconazole cover? Is it a broad spectrum or a narrow spectrum antifungal?
It's a broad spectrum, ma'am.
Is it a fungicidal or a fungistatic? Doesn't matter. Not to worry. Okay, well done, Vaishnavi.
Very good. Yeah.
Thank you so much, Vaishnavi. Okay, so now we'll have Vivek Naik. Hi, Vivek.
Oh, hello. Am I visible?
Yeah, you are visible. Can you share your PPT?
Yeah. Just a minute.
Yeah.
Is the PPT visible?
Yes, your PPT is visible. Judges, is the PPT visible to you?
Yes, yes.
Yes, please go ahead, Vivek.
Respected judges, organizers, and my dear friends, a very good evening to all of you. My name is Vivek Naikam. I'm an intern from Kasturba Medical College, Manipal, and I'll be presenting a case titled An Ominous Discovery, Fatal Aspergillus Nidulans Brain Abscess in a Patient with Severe Leptospirosis. Coming to the history, this is a case of a 54-year-old male agriculturist, nil premorbid, presenting with a complaint of high-grade intermittent fever of 4 days duration with right upper quadrant pain and jaundice. The associated symptoms were chills, rigors, vomiting, itching, high-colored urine, and myalgia. He was later diagnosed with severe leptospirosis, with acute kidney injury, hepatitis, and myocarditis, which were managed with intravenous ceftriaxone and other supportive measures. He was improving with these measures. Later on, he had an episode of generalized tonic-clonic seizures. In search for a trigger for these seizures, a non-contrast CT scan was done of the brain, and this revealed
Vivek,
acute left subdural
your
hemorrhage.
PPT is not, the slides are not changing.
He's actually not on full screen, no?
I'm on full screen now.
No,
just run the slideshow.
I have run the slideshow only, ma'am. Is it not coming?
No, the first slide is only visible. Share again and start.
Okay, I'll stop sharing and share again.
Yeah.
Can you see it now?
Yeah, I can see.
Should I start from the beginning?
Just go to slideshow. Go to slideshow. You're not on slideshow. Yeah.
Now you are on slideshow. Now.
Okay.
Now you are on.
Just We are actually running short on time. It will be great if you could start from where you actually left.
Okay.
Yeah.
So after he got seizures, it revealed non-contact CT scan revealed acute left subdural hemorrhage. This was later treated, and there was persistent fever despite treatment, and this led to the diagnosis of catheter-associated UTI. Later on, after 2 weeks of admission, he developed left-sided hemiparesis with new onset of fever. On this, MRI brain was done, and this showed an acute infarct in the right parietal region in the periventricular area. He was later treated with antiplatelets and statins, thinking this is an infarct, ischemic stroke. But however, the weakness progressed and the fever persisted, and a repeat MRI was done. And this showed an increase in size of the lesion, a progressive increase in size with surrounding edema, and this was suspicious of an abscess. On clinical examination, initially the vitals were stable, patient was febrile and icteric, and abdominal examination showed right upper quadrant tenderness, but there was no hepatosplenomegaly, and other systems were normal. After 2 weeks, that is after he developed left-sided hemiparesis and new onset of fever. Coming on to investigations, complete blood picture, as you can see, patient's blood parameters progressively deteriorated, and hemoglobin and hematocrit all fell down, whereas total leukocyte was elevated, and platelets also fell down. The nadir of platelets was at 24,000 platelets per microliter. Renal function test and electrolytes. Renal function test and also progressively worsened. And the peak of serum urea was more than 240 milligrams per deciliter, and that of serum creatinine was more than 9.7 milligrams per deciliter. This progressively, on treatment, this progressively resolved. Liver function test also initially progressively got elevated. There was a rise in liver enzymes and also bilirubin, and there was a drop in protein. But on treatment, subsequently, all these values recovered. Microbiological investigations, initially blood cultures were sterile, and malarial test was negative. Serology showed a positive IgM lepto, whereas the other serological investigations came out negative, such as IgM scrubs, HIV serology, and autoimmune serology. Later on, biopsy of the lesion was done. This biopsy was done twice. Initial biopsy was done, and in that, histopathology came negative, but subsequent biopsy showed growth of fungal elements. Culture was also done twice. The first time it came inconclusive, but second time it grew Aspergillus nidulans. Other tests were also done from brain biopsy, such as test for Aspergillus galactomannan, which came out positive, and TB. PCR test was done for TB, and that came negative. Chest X-ray was done, and that came out as clear. Later on, other imaging investigations were also done. Initially, when the patient presented with seizures, a non-contact CT scan was done, and this showed a left-sided left-sided subdural hemorrhage, this is a CT scan. It shows a
1 minute left,
lesion.
1 minute left.
Yeah, it shows a hyperdense lesion suggestive of acute subdural hemorrhage. And subsequently, an MRI was done when patients were presented with left-sided hemiparesis, and this showed a tiny lesion on the right half of the brain in the periventricular region. These are subsequent images, both CT scan and MRI of the brain, showing expansion of the lesion and also surrounded edema associated with it. These are both MRI images, T2 weighted and T2 flare, showing the expanding lesion. These are coronal images of CT scan and MRI brain showing expanding lesion and associated edema with it. And this is a post-surgery CT image showing hemicranial defect. For this case, a hemicraniectomy was done to relieve the excessive pressure. And it also shows a midline shift of intracranial
timer.
Yeah. Can I continue if it's possible? I just have to.
Yeah, just give your final diagnosis and management.
So, final diagnosis is a right fungal cerebral abscess caused by Aspergillus nidulans. Status post hemicraniectomy, and it is associated with left hemiplegia and right lower limb monoparesis, with left frontotemporoparietal subdural hemorrhage, severe leptospirosis, acute kidney injury, oliguric, and catheter-associated Enterobacter faecium UTI. Thank you.
So Vivek, why do you think he got the Aspergillus infection? Why? Because he initially began as a leptospira or something, you know.
Yes,
why? Were there any predisposing factors or what happened?
Sir, as far as predisposing factors are considered, the patient was not immunocompromised, did not have HIV or anything. But since the patient is a farmer, he was probably previously exposed to the aspergillus, and maybe it might have formed a small nidus in his brain already. And when he got leptospirosis, he developed sepsis. And during sepsis, there is, during the second phase of sepsis, that is the anti-inflammatory phase, there is immunosuppression systemically. During this, the pre-existing fungal nidus might have expanded and led to an abscess. That is our hunch about it.
Okay, thank you.
Well done, Vivek. Just one quick question. Could this thing have been prevented?
Prevented, ma'am. Maybe it could have been prevented by giving a dose of like empirical dose of antifungals when the patients were in sepsis.
At that time, there was a small lesion which was visible, no?
It was visible, yeah. Small lesion was visible.
Yeah. Right. Thank you.
Thank you, Vivek. It was a really great presentation.
Thank you.
Yeah, all the facts were up to mark. Thank you.
Thank you.
So now we have with us our last participant, Ishita. Hi, Ishita.
Hello.
Hi, Ishita. Yeah. Can you share
Hi.
your PPT,
Yeah.
Ishita?
Yeah, absolutely. Well, give me a minute.
Yeah.
Before I share my PPT, I'd just like to say that basically there have been some new developments in my case in addition to the
Ishita,
things
your
that are
voice is
noted
lagging.
in the abstract. So I just wanted to clear that.
Your
Hello?
voice is lagging, Ishita. Could you
Okay,
sit in a
okay.
better network?
Okay, let me try. 1 second.
Yeah. Yeah, sure.
Say the last case. Is it better now?
Yeah, it's better now.
It's better. Okay, great.
Okay, can you share your PPT, Ishita? And please unmute yourself. Yeah, it's visible.
Good evening, everyone. I'm Ishita Lanjevar. I'm a second year MBBS student at SAGE GSMC in KM Hospital. Today, I'm going to be presenting a rare case of small vessel vasculitis mimicking Koch's disease. So, pardon me, there seems to be a lag. Is my PPT moving for y'all?
No, it's not.
Okay. Sorry, my laptop is frozen. Give me a minute. Yeah, okay. Yeah. So mainly in this case report, I'm trying to answer the question of what is polyarteritis nodosa and what is deficiency of adenosine deaminase 2. So both of these are very, very similar diseases and they have very, very similar clinical presentations, which is why clinicians often confuse the two. So both of them represent themselves as vasculitis and have new onset hypertension, elevated inflammatory markers, mononeuritis, myalgia, skin lesions, and rashes. Both of them show an absence of autoimmune antibodies such as ANA and ANCA. Both of them have angiographic evidence of aneurysms and segmental stenosis. So how do we really differentiate between the two is what I want to illustrate through this case report. Perhaps the etiology is one way that we can, because PAN is seen in 1/3 of patients having chronic hepatitis B infection, whereas DADA is a genetic autosomal recessive syndrome, and it is seen due to a mutation. So let's get into the history. This is an 11-year-old female child who's complaining of abdominal pain for the last 4 years. She has failed to gain weight, and recently in the last 1.5 months, she has a blackened and painful right ring finger, and she has chest pain on the left side. Her past history has been in KM itself. At ages 3, 7, and 10, she has come with different symptoms. At age 3, she was treated for Koch's, even though she had no evidence for the same. At age 7, she was admitted with abdominal pain and 1 episode of convulsion. At age 10, she showed new onset hypertension. So it's a very slow onset of symptoms, as we can see. Her clinical examination, as I'd like to demonstrate with this video, was here you can see the necrosis, the left-handed digital gangrene, and we can see an eruptive lesion on her left hemithorax. So on clinical examination, we were able to see these things. When we performed clinical investigations, her inflammatory markers were high, which pointed to a systemic inflammation. Her skin biopsy showed necrotizing inflammation of her arteries, which pointed to vasculitis. Her specific antibody tests, which I mentioned before, ANA and ANCA, were negative. So that is already narrowing it down to PAN and DADN. Whereas her renal Doppler showed there was necrosis, wedge-shaped necrosis, which pointed to renal ischemia. Further, her radiological investigations are very interesting, as we can see a characteristic berry or balloon-shaped appearance in all of these three images. These are just some of the relevant investigations. Now, the differential diagnosis. We had narrowed it down to 4. PAN, ANCA-positive vasculitis, HIV or COX, and DADA. ANCA-positive vasculitis and COX were cancelled due to our investigations, clinical investigations. What remains with us is PAN and DADA. So what are the factors that make us think that it is PAN? One is the absence of ANA and ANCA, as we've mentioned before, and then the absence of glomerulonephritis and absence of lung pathology.
Which are the 1 minute left.
All right. Which are the criteria that make us believe it is DADA? It is the expansion of the cutaneous findings to include necrotic ulcers. Also, the fact that the patient never had hepatitis B, and the fact that she's a young child. PAN is usually seen in 65 plus old adults. So these are the things that led us to the final diagnosis that the patient in fact has DADA, and she was treated accordingly. She was treated for both PAN and DADA because the treating physicians were still not sure because of the overlapping symptoms. So for PAN, she was given glucocorticoids and cyclophosphamide, while for DADA, she was given TNF-alpha inhibitors like infliximab. And she is now doing well, the last we checked. Yeah, that's it. Thank you.
Why did you give her cyclophosphamide? Sorry,
Nina.
Yeah. Why did you give her cyclophosphamide?
Sorry, ma'am. Can you repeat that, please?
Why did you give her cyclophosphamide?
Cyclophosphamide is generally
A child, you don't usually start the child unless it's absolutely necessary.
Yes, ma'am. Yes, ma'am. So the reason the glucocorticoids itself were not working is what they thought initially. And that is why, and because it had spread to all different systems as well, not only renal.
Specifically, which system? Specifically for which system do you normally give cyclophosphamide? Involvement of which system?
Intestinal, I believe. Intestinal and renal.
Renal, yes. What are the side effects you look for in a patient? You have to give long-term cyclophosphamide.
I'm not aware, ma'am. Can I take a guess?
Yeah, of course.
Are we looking at like obviously depressed immune system, but along with that severe hypotension as well?
No, hemorrhagic cystitis.
All right. Okay.
Okay. Right. Thank you. Well done.
So Ishita, nice case. In a tough case. Did you do genetics?
Sorry, ma'am.
Because diagnosing adenosine deaminase variation is simple. You can just send a genetic study and you can figure that out. Was the genetic test done? Did you do a sequencing?
No, sir. The genetic test was not done in our hospital. It's kind of an expensive test.
No, but,
so we relied on a treatment method to see
whether
that
will not figure out, because if you have a diagnosis possible for a disease that is life-threatening and something that's going to last very, very long, doing genetics is perhaps imperative. We can't say at this time it's not possible because you're putting this child on long-term therapy with a very expensive medication.
Yeah.
I'm sure infliximab is more expensive than a genetic study at any time. So obviously, I think a genetic study would have been useful. But an interesting case nevertheless. Very good.
Yes, sir.
Thank you, Ishita. The presentation was really good. It was up to the mark. Thank you. Arvind sir and Neena ma'am, could you switch on your video, please? Yeah, we are at the end of the session.
Yeah.
Yeah.
Okay.
Okay. Hello. Yeah. So I would like to extend my gratitude to our esteemed judges. It was an honor and privilege to have you on the panel as a jury today. It was pleasure learning from your insights and constructive criticism. Sir and ma'am, we all students read through your books before our exams, through Ghaya and through the dermatology synopsis. They are really great books, and it really feels glad today to have you on board as judges, as mentors. There is so much inspiration which we take from you every day. And I would also like to thank all the participants for their enthusiastic participation. Each one of you did an amazing job. And the results will be announced on 14th July. Thank you. And Neena ma'am and Bagga sir, it's up to you if you want to add few words. And one line just, State GSMC and KM Hospital is really glad to have you as judges.
Dr. Neena will speak first. Yeah.
Yeah, okay. You know, a very quick comment. You did brilliantly. I think all of them, I think, Arvind, I'm very envious of them. I'm sure we never did this good a job when we were undergrads.
Yeah.
We didn't even have PPTs, of course, and we used to, I think, speak with slides. Arvind, you're also the same era, I think.
Yeah, absolutely.
Okay.
Yeah. Transparencies. Not even
slides and then OHP. Yes, OHP slides. Yes, then gradually we graduated over a period of time. Quick questions, I think very important. You know, some of you people exceeded your time, so I think it's a good idea to rehearse. Secondly, on your don't write too much. I think I think you have on your slide, the better it is for the person who's seeing your presentation or hearing your presentation. So you can easily avoid verbs, articles, and the other thing you should avoid too much is, too much animation, because that tends to distract from your presentation. A good way to reduce time would be to have your pictures and your text on the same page, So trying to show a clinical this thing, then you just write the text on one side and have the images. I think Arvind would like to add to some of what I've said. I think that's what I really wanted to. Yeah.
I think the overall quality was very good, and it's thank you very much for having us here. And the overall quality of the presentations was good. Yeah. I think I really liked some presentations. They were really, up to the mark. I think what you should tell them for future, Dr. Desai, is that perhaps, they should be focusing on not the rarities. It has to be the commoner cases that they are seeing.
Yeah.
Rarities is good, but I saw a lot of surgical cases where the diagnosis was made by the surgeon during the time of surgery. So I think we should
any message for the young budding clinicians?
We should encourage more clinical patients, like what Ishita just presented, or maybe others also presented. So we had that patient who had that parvovirus disease. So these cases are interesting. They also test their ability to be able to discuss a patient academically.
Yes.
And so I think we should have strong. So it's good to have strong cases. Strong clinical cases where you make a diagnosis bedside, or at least by basic tests. So perhaps, but overall, I think I'm impressed, and thank you very much for having us here.
Thank you so much, ma'am and sir, for your precious time. Thank you.
Thank you for having us both, and thank you. We connected, Arvind, after maybe a month.
Yeah. Okay. All right.
It was really pleasure to have you on board. It was a great experience. Thank you. Yes.
We'll mail the Google Sheet to you.
Yeah, tomorrow you can.
Okay.
By tomorrow. Thank you so much, sir.
Thank you for giving us the opportunity to interacting with young minds.
Yeah.